Yeah. You're not gonna bother me.
I still ask for
I'm in survival mode.
survival mode, candy bars and whatever else.
Oh, they're not candy bars, they're Jenny Craig diet bars.
I give on all that.
Yeah, I get them out for the morning
I'm
while
up
we're
to
at it.
292 pounds now, so what's left in life, right?
I'm almost down to 3.
I would have never guessed you were above 3.
Yeah. And if not,
Oh, my worst on 340. I got a lot of muscle on me that weighs more.
Oh, I understand.
So,
I know exactly what you're saying. So we're going to go here,
okay.
video conference.
yeah, you can testify to them. Show them all of them.
I'm going to go to Zoom.
Welcome to Zoom. Please press pound, then enter your meeting ID
945 7 2 3
Double check, make sure she
5 8 9
Please enter the meeting passcode, followed by the pound sign. You are in the meeting now.
So there's your document that you're showing.
Listen, he's telling you.
When he's talking to them, I'm sorry, Paul.
That's all right. No, you're sharing the screen.
Okay,
Now, if you were to unshare,
so stop share.
uh-huh,
All right, perfect.
now,
Awesome.
we should be,
Should I stop my video so that I'm not up there?
you can,
Okay, that way it's just gonna be Dr. Hacker.
yes.
Okay. All right, I'm gonna leave my computer on so I don't lose it and screw something up. How's that sound?
And just to give you another idea of what it's going to look like,
Okay.
I'm going to join from my phone.
Okay. You know what, I'm gonna put it up there on that small table. How does that sound like? Plug it in there.
So there I am.
Hey, this is how this will be. The way he's got it set up, he's acting as a witness right now.
Okay.
So,
Then if I let's see what that looks like. Oh, good. Okay, perfect. Thank you.
Doesn't that look nice? And the little picture in the corner is actually what the person on the other end
Yeah.
sees.
So that works out perfectly.
Yep. And you've got it on your screen there.
So I'll have a microphone and still be able to access it.
Yeah, it's using all the microphones in the courtroom. Well, the ones that are still plugged in.
Let's see what I can do about this. I don't think I'm going to do that first. I'm going to talk about
Okay,
that on here.
unfortunately, because I joined and I'm the meeting host, when
Yeah,
I leave, I have to assign a host.
that would be me, I take it?
Since
No.
you're the only other one in the.
Okay,
yeah.
it's going to be me. So if we have problems, it's all my fault is what you're saying, right?
It's all your fault.
No pressure.
Yeah, I was pleasantly surprised.
There's that. I still have to start.
I figured we'd have an ice storm, we wouldn't be able to move. Oh, and you guys were talking about what's the theory, we're putting the back row with a half, three-quarter sheet, but
They didn't get it done last night, though?
they took it out the plastic. And when they were grading, it was so cold, that someone cracked. Oh, they had to reach up.
Paula, do you need anything from me as far as exhibits here?
I think I've got all the exhibits. I'm just trying to label what I've got saved so I know which one to put on the screen. Does that make sense? All right. All right, so this is going to be 16D. All right, so let's close it out. Rename. This may take, oh, what do you mean I can't rename? Oh, you're killing me.
Well, my first focus has got to be that young lady up there recording things, and then I'll try to see what I can do for you. Because if I got it too loud, we'll get an echo back, and then we'll get this.
Oh wait, hang on. I'm good. All right, I think we're good. Thank goodness.
I can send it to you via email, and you can take it out of email.
So let me see if I can find it real quick and put it on my. Hang on, let me see if I've got it in the Husel file. Opiate conversion chart, opiate conversion chart. Crap. Okay, let's go here. Here we go. Make sure that's the right one. That's not the right one. Okay, let me see if I can get back into email quickly if it wants to cooperate. There we go, just came in. Desktop. Desktop. What's that exhibit number?
There, it's 19.
19. Okay. Morning. Are you or Diane doing Dr. Hagris?
That would be me.
All right, I got it.
I'll be done here.
I don't know, take your time. Take your time.
Okay, so these are all the palliative order sets and the withdrawal policies I'm going to show to Dr. Hagris. These are the medical records I'm going to refer to. I may not refer to all of them. Those are the relevant ones I put out last night. And then an opiate conversion chart. So those are all copies for you, sir. And the way we're going to have to do this is I'm going to have to share it on the screen so he can see it.
Okay,
You'll still be able to see him. We just tried that out.
okay.
Where'd it go? maybe. I don't think it's saved.
Tell Paula, because
I'm listening. Live stream here, I heard that. Desktop, let's go into Husel. No, I just want it here. Okay, save, maybe that'll work.
So, Paul, we may have a few more. Dr. Swanner is going to testify via Zoom. That should be maybe Tuesday, maybe Wednesday. I mean, I don't know how far
Found
we're
it.
going to get, but then we have,
So I can get it.
we will, then we have a few nurses down the line that will be testifying via Zoom. And we'll get you all that information. But so I can see at least
Before the 25th?
of March. I hope so. Hopefully, who's taking over for you?
I have no idea yet.
Will our IT people be able to come in and help us with this? Will they have the access that you have to help us if we have issues? If it's after the 25th?
Well, you also have Darcy in the mix too that can also help.
All right.
Much to your dismay, right?
It's only 150 per hour
There you go.
consulting fee.
You're cheap.
Yeah. I am cheap.
I mean, most guys are getting $2.25 to $2.50.
Depends on who it is that's calling.
Yeah, that's true.
Donnie, have you got everything you need? All good. He's not listening.
Who?
Donnie looking down to.
Donnie, you got everything?
So Paul, they
Channel
should be able to
six?
just get in here.
You got everything? Good.
He should, when he pushes on the link, he should just pop up, correct? Okay.
That's not good.
Oh, is it breaking or coming?
Yes, it's-
Oh, that's bad.
It's bad.
Did they print it out for you this morning?
Okay.
Do this.
Okay, see if they will just go back and visit them back in the jury room. They were a minute ago.
Later, probably.
As long as it doesn't fall off in the meantime, right?
Oh, yeah.
Okay, come on, let's
That's the
get,
problem with it being out.
just run right through them.
Yeah, yeah.
They didn't really clamp it on very good.
Uh-uh.
There's a whole lot of gap there that shouldn't have.
My goal is at 9 o'clock, but I don't think that's gonna happen yet, because I haven't seen the doctor on the screen. And the jurors want a minute with the therapy dog. Is he gone? The jurors would like to meet the therapy dog.
What's that?
The jurors want to meet the therapy dog. I should have never brought them in here. Well, as soon as Darcy saw the dog, I know it's all over the courthouse now. I mean, the way Darcy was petting him, she went back there with dog hair all over the place. Ah. We're missing somebody on the screen.
Yeah, we don't have the doctor yet.
Yeah, he's kind of important, don't you think?
Just a little bit. Whatever. Yeah, and we're not. We're gonna find out, aren't we?
So if I,
Not heavy.
okay. That was the other thing I was worried about. I'm like,
Yeah.
so you don't delay.
Yeah, no, he does not have a heavy accent at all.
So my apologies, fine.
Yeah, no, yep, no, he's actually, he's been in the United States since, I mean, he went to his fellowship here in the US, so. Actually born here, moved back to Egypt when his parents went back when he was 3 and then came back for medical school and everything, so. No, but whatever works for now, right?
Yeah, I know. Take a break till Randy Miles gets here.
Bang, boom.
I meant to do that.
Well, that's expensive hardware there.
I'm good. Just making sure my microphone is still on.
Is the charger even plugged in on this
It is
place?
plugged in, but
Yeah,
it doesn't
wow.
appear to be charging. Do you mind if I run down with your shield?
Yeah, go ahead. We don't have a doctor yet on the screen. I'm not gonna bring the jury out until he's ready.
I don't think this thing's very charging. And Simon.
Okay, well, let's tighten that.
All right.
Yeah.
I broke a nail.
Bagels, dogs.
Yeah, cost and take his time.
Are they enjoying Simon?
They are.
Do we have the good doc coming on or not?
I was listening to it, Nadia, but I also.
Ms. Sawyer, do we
Yes, sir.
have the good doc coming on or not?
He verified it with Mr. Gobble last night, that he had the link and that he would be on.
There, is that him coming on?
That is him.
Hi, Doc. Can you hear me?
Hello? Yes, sir. Yes, Your Honor.
Okay. We're getting jurors organized. Just chill there for a minute.
Okay, okay.
I'm going to go on video just for a minute and let him know I'm here. Dr. Hagris,
I'll be asking you a question.
Oops,
Hang on.
You gotta mute your mic.
Yeah, I'll be asking your questions, but I'm going to put my video off so they only see you, okay?
Oh, okay.
And I'll also be sharing the screen to show you exhibits.
Got
Okay?
So, while we're off the video,
Yes.
this is what you see.
Okay.
So, assuming that whatever cameras are on, what you
Okay.
Can you see the overview of the courtroom? Now you'd see a picture of me.
Yeah.
Okay. We're just making sure the technical's working.
Let me do one more thing. Let me make sure if I share, he can see it. Hang on. Where'd it go? I had it up. Dr. Hagris, can you see that?
Yes.
Okay. It's not.
Between batteries and puppies.
Judging when Sam comes back, we may want to resolve a potential issue.
Okay? Let's chill, she's walking in.
Excuse me, sorry.
But there's still plenty.
Sorry? I handed them to Jose. Yep, he's got a copy of everything. Yeah.
Okay, we're on the record. All counsel are present, along with the defendant. There's some preliminary matters we need to deal with. Mr. Baez, you had a preliminary matter?
Yes, I just wanted to make sure that the state is not anticipating calling Dr. Hagris as an expert witness. My understanding is, if anything, he's a fact witness, and to elicit opinions on specific matters, we have not been given any notice of that.
Your Honor, he is going to be here as a factual witness to talk about some hospital policies that he's familiar with. We're not intending to use him as an expert witness. He did have involvement with some of our victims. We're going to talk about his involvement. We did not provide an expert report on him because he's not being treated as an expert, other than the fact he's a treating physician, which may be a good time to raise the fact that we still don't have expert reports from the defense.
We forwarded them to you already, right?
We have
Last night, yes.
We didn't get any.
Okay, well, that's a logistic issue you all can deal with on the break. Okay. Anything else for the record?
No, that's it. That's all I wanted to make sure of.
Okay. Let's bring him. Is there a problem?
No.
Are they still playing with the puppy?
No. So,
Okay.
Susan was in the background and,
What did Susan want?
well, I don't know.
Buck, I've got to do some housekeeping first. We'll be right with you, okay? Did you hear me, doctor?
Yes, sir. Yes.
I got to do a little housekeeping with the jury, and then I'll be right with you, okay?
Okay, okay, Doc. Okay.
All rise.
Thank you. Please be seated.
Good morning, ladies and gentlemen. Sorry to interrupt your wonderful morning so far from what I hear. You'll notice the plexiglass is down between the second row. They had problems installing the second ones because of the split, so you can actually reach out and touch the person in front of you if you want. The plexiglass will be up, the 3/4 glass will be up Monday supposedly. So I was just letting you know that. Our first witness today we're doing via Zoom, okay? You're to treat him as if he were live here on the stand, okay? We've got it set up with technology. Technology is a wonderful thing. We worked our way through all the things. We should be in good shape, okay? So with that, doctor, raise your right hand. You solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God.
Yes, Your Honor.
Okay. Ms. Sawyer?
Thank you, Your Honor. Doctor, could you please state your full name and spell both your first and your last name for us?
My full name is Saad Ahmed Hagras. My first name is Saad, S-A-A-D. Last name Hagras, H-A-G-R-A-S.
And sir, you're testifying via Zoom because you had a family emergency and are out of town because of that. Is that correct?
Correct.
Dr. Hagras, where are you employed?
Where, welcome, sir?
Where are you employed? Where do you work?
I'm employed in Mount Carmel System through Mount Carmel Medical Group. And I start working in Mount Carmel West, and right now I'm in Mount Carmel Grove City.
And when did you first start working at Mount Carmel West?
June 2013.
And what is your job position with Mount Carmel?
I'm an acute care physician, acute critical care physician. I work nights from 7 p. to 7:30 a.m.
And have you always worked the night shift?
Yes, ma'am.
And let's talk a little bit about your background. What type of education do you have to hold your current position?
I finished 6 years of medical college in Ain Shams University in Cairo. Then I did my exams and I came over to US and I did my residency, 3 years internal medicine in University of Maryland's East Campus in Baltimore, Maryland.
And when did you receive your licensure, sir?
I received my license in Ohio.
And what year?
It's 2009.
And do you have any type of continuing education requirements in order to maintain that licensure?
Yes, I do.
And what are those, sir?
It's online courses and some seminars.
And has your licensure remained in effect in Ohio since 2009?
Yes, ma'am.
Are you board certified in any type of medicine?
Yeah, I'm board certified in internal medicine.
And how long have you been board certified, sir?
Since 2012.
Now, you indicated you worked the night shift with Mount Carmel. Are you assigned to any specific department?
Only ICU.
And have you always been assigned to the ICU?
Yes, ma'am.
Can you tell us a little bit about what type of training, on-the-job training or orientation did you receive when you first started at Mount Carmel Medical Center West?
When I came, I had only like a few hours orientation with a doctor. His name is Shiraz, or something like that. Yeah, I don't remember exactly, but he was a locum, and he used to cover ICU nights. So he gave me an orientation for like 3-4 hours. He showed me the ICU, the layout, introduced me to the charge nurses, and showed me the EMR system. And I had also, before that, I had 2-3 hours IT training for the EMR,
Okay.
electronic medical record.
Okay, that was what I was going to ask next, so thank you, sir. Did you receive any type of training from Mount Carmel regarding, in this type of circumstance, or to use this type of procedures or medication?
No, ma'am.
Okay. Did they show you anything or refer you to anything that would help you reach decisions, say if you were doing a palliative care withdrawal?
Well, they showed me the main website of the Trinity, and there's a link for like health stream, link for hospital policy and procedure, link for medication interactions.
Dr. Hagris,
Hey,
I'm going
hold
to stop
on
you
one
for a
second,
second.
Doctor.
We have an objection.
It's non-responsive.
Okay,
She asked him if
overruled.
he was trained, he just started to describe the system.
I understand, I overruled it.
Okay, go ahead. You were indicating they showed you the different
Objection,
systems.
leading, and that's not what he said.
Okay. We're gonna take it back. Technically, she's catching up on the question, overruled. He was in the middle of his question.
Correct.
You can ask him to continue on, I would guess.
Please continue on, Dr. Hagris. If you need me to repeat the question, I will do so.
No, they showed me this like main website that has multiple links for like, if I need up-to-date, if I need the policy procedure of the hospital, if I need medication interaction, if I need a physician, links, if I want to get like physician cell phone, if I want to put a voice. So this showed me this multiple links,
Okay. And in the years you've been practicing at Mount Carmel, have you utilized those links?
Sometimes.
Okay. What circumstances might you utilize those links for?
Well, I always like try to find, like when I try to call a physician overnight, I can go to the system and find who is on call so I can get hold of him. Sometimes if I want to put a voice, I remember I put a voice in 2013. So yeah, I utilize it sometimes, yeah.
Okay. Now you indicated a voice. What is a voice? What does that mean to us?
A voice, it's when I see an error, medication error, I put a voice for this. It's like a complaint report.
Can you repeat that? Our court reporter, it glitched a little bit, so our
Okay.
court reporter's trying to catch what you said.
It's like a complaint report. If I have a complaint regarding an error of medication, I can put it in. So this is the link, I will use it.
Okay. Now, as a physician in the ICU, how would you obtain medication for a patient?
Well, if I need to give a medicine to a patient, there's two routes. There's a stats and routine. So I need to go to the EMR, electronic medical records, and place an order as a stat or routine, and the nurse will call the pharmacy if it's stat to get its stats, and routine just will come on its time.
Okay. And so you place the order, and who actually pulls the medication?
The nurse.
Do you know where the
It's
nurse?
either.
I'm sorry, go ahead.
So it's either the medicine will be delivered to her, or she can pull it out from the Pyxis after she talked to the pharmacist.
Okay, so what is the Pyxis machine?
Pyxis machine is like a medicine closet, you know. It's just it has drawer. It's a cooled, so the nurse can go in and put her ID and get the medication out.
Okay. Are you aware of the override system that can be used with the Pyxis machine?
Yes, ma'am.
Tell me about that.
Well, my knowledge is limited that it's only existed, but I don't know how it works really.
Okay, that's
I
fair.
know the nurse only the one that can do that, but I never got involved in any override really process.
What if there's a code in the ICU? How do you handle the obtaining of medication at that point?
We have a crash card. It's a blue card. You know, we have it, multiple ones in the ICU, and we pull it, and we have all kind of cardiac medications in these cards. So like epinephrine, atropine, dextrose, this kind of like cardiac medication. Then I start resuscitating the patient. Also, the pharmacist will come to the code blue, and he will have his own cards, and he will provide us also with these medication.
So if there's a code, you're not using the Pyxis machine at all?
No, ma'am. No.
Okay. Dr. Hagris, are you familiar with William Husel?
Yes, ma'am. Yes.
How do you know William Husel?
Dr. Husel, he started August 2013, and he had an orientation with me for like 3-4 hours, and I showed him the same, what I had, the layouts. I introduced him to the nurses, showed him the EMR, our on-call room, our codes, the code combination for the room. And then he started with as alternating shifts with me. It's about 1 week on, 1 week off. Then I also met with him in multiple meetings with Dr. Swanner and Dr. Rolston.
Did the two of you have the capability of communicating in between shifts if you needed to?
Dr. Husel, he didn't have a cell phone, so he had an email, and he was really good about responding to his email. So every time I send him an email, he would respond to me in 3-4 hours.
Did Dr. Husel ever ask you about palliative withdrawals or palliative ventilator extubations?
No, we never talked about any patient management. Our talk was about coverage, because I used to ask him to cover me when I go to Egypt, when I went to get married, and he was so nice to cover me all these times. Plus, our talk was also about our contract renewal, but I don't recall at all that we talked about any patient management.
Okay. Dr. Hagris, during the time you've been with Mount Carmel West in the ICU, had you ever had the opportunity to perform a palliative withdrawal or a ventilator extubation that was palliative?
I'm sorry, say it again?
Sure.
To what?
During the time period that you were employed with Mount Carmel West as an ICU doctor, did you ever perform a palliative withdrawal?
Yes, ma'am.
Tell us what you would do in that type of circumstance.
Well, the most common scenario in my practice is a patient has been in ICU.
hang on, there's an objection, sir.
relevance, and this is the issue that we discussed previously.
Okay, I'll permit it.
Go ahead, Dr. Hagris, you can answer the question.
Okay, the most common scenario in my practice is a patient that has been in the ICU for like some time in ICU, days or weeks, and there was an ongoing discussion with the family, and the patient, like it's either the patient declines in my shift or the decision already made before my shifts, but the family gathers in my shifts and they decide, okay, we are ready, and I'm the one on call, so I go in and I confirm that we are on the same page, and I change his code status to do not resuscitate comfort care, and I explain to the family the process of the extubation, that I'm going to stop all the infusion 30 minutes before taking the tube out. I'm going to give a dose of morphine and Versed 10 minutes before taking the tube out. And after taking the tube out, he will have a comfort oxygen. Then after that, every 15 minutes, he will get morphine and Versed till he passes. And during this also discussion, the nurse will be here. I offer also a chaplain support, and like after he passes, I will come back and pronounce him.
Okay, so just a few questions off of what you just told us. You said you would order a DNRCC. First off, what is a
Yes.
DNRCC?
It's a do not resuscitate comfort care.
Okay.
Do not resuscitate comfort care, and this is like when I perform any palliative withdrawal, I do that. So this means I'm not going to perform any line of treatments. I'm just comforting the patient. So I'm taking the tube out and give him medication and some oxygen, and this is what's DNRCC.
Okay. And you said you you order it. How do you place that order?
Well, there's an order set for palliative ventilator withdrawal, and there's a check box that I can change it to DNRCC. There's other check box, if I remember, it's to take the tube out. Check box to contact loop organ donation agents. So it's part of the order set.
Okay. And you said you go in and you check it. Is that on what you call the EMR, the electronic medical record?
Yes, ma'am.
So that will physically show up as a order in the medical record?
Yes, ma'am.
Okay. And
Yes,
you
ma'am.
referred to an order set, sir.
Yes.
All right. Jose, this will be the first one for the order set that I handed you. That's from 12/7/10 to 8/17/16. All right. Sir, I'm going to show you in a second, as soon as I get to the right screen, what we have marked as State's Exhibit 17A, as soon as it pops up there. Can you identify this for us?
Yeah, this is, it's date 12/7/2010, okay? And this is revised thermal ventilator withdrawal plan of care. Okay, yeah, this is what I'm using to communicate order patient withdrawal support.
Okay.
Yeah,
So this is what you called the order set, am I correct?
yes, ma'am.
All right. And you pointed to the date 12/7/2010. Am I correct? That's where it begins, and then this policy went through August 17th of 2016?
Yes, ma'am.
Where did you access this at Mount Carmel, sir?
This order set?
Yes.
Yes, this is in our electronic medical records.
Okay. All right, and tell us a little bit about what this is exactly and how you would utilize it. And tell me when I need to move the page up so you can see more.
This is the beginning of the order set, so if you can scroll down. So I need to check these boxes. So I will check these first 3 boxes, okay? So then when I go to the medication, I will find where I can give 10 minutes. Yeah, this one. So so I will check the first box, pharmacy. If patient is on paralytics, I will need to stop that. Then the second box, I will check it, and I will use the 5 or 10 milligram, which is 10 minutes before taking the tube out. And I will check the second box, the third box. Then I will choose, I will check the fourth box. I will use maybe, this is when, okay, so, I will check the third box for the first hour. Then I would choose like maybe 4 milligram every 50 minutes. Then the fourth box, I would check it if the patient survived for more than 1 hour. I will check 4 milligram, and I can choose between morphine and dilaudid, and I always like choose morphine, sometimes dilaudid, but mostly morphine. And then I will scroll down to get to the Versed and Versed injection. This one I will check it, and it's 2 milligram IV, and this is, I will tell the nurse to give it also with a morphine 10 minutes before taking the tube out.
Okay.
And if you can scroll down, if you can scroll down, and okay, then I will check the Ativan. Here, it's 1 milligram every 15 minutes after taking the tube. Then I would check the Ativan if he survived more than 1 hour, 1 milligram every 4 hours after first hour if he makes it after 1 hour. Then I'm going to check the Atropine for any increased salivary secretions. And I'm going to check the oxygen therapy, and I'm going to specify it's 2-liter oxygen for comfort. Then I will sign out. I will sign with my name, and I'll just put it through here.
Okay, so all this would show up on the EMR.
Yes, ma'am.
Now, you said first that you stopped the paralytics 30 minutes before. Why do you do that, sir?
Well, because I need to assess the patient to see if he is in pain or any air hunger after taking the tube out. So I need to be sure that paralytics are out of his system so I can get an accurate assessment.
All right. And you indicated you usually start with, did I hear 5 milligrams of morphine? Or did I say that incorrectly?
Yes, 5 milligram, 10 minutes before taking the tube out, with 1 milligram of, or 2 milligram Versed also 10 minutes before taking the tube out.
All right. And just so I'm sure I know what you're talking about, Versed is the brand name for midazolam, am I correct?
Correct, ma'am. Yes.
And the Dilaudid is the brand name for hydromorphone.
Correct.
Okay. You mentioned the atropine for secretions. What does that mean to us?
For salivary secretions, some patients, when they take the tube out, they will have a lot of saliva, and this will give them a lot of discomfort. So we give them atropine to dry out these secretions.
The end there says oxygen therapy. Explain to us what you do on that.
It's a nasal cannula. It's a 2-liter nasal cannula. Okay, we put it for the patient for comfort.
Okay. And then you also mentioned extubation. Are these patients on ventilators typically?
Typically, yes.
So what do you, describe to us just briefly, when you say extubation, what are you talking about?
I'm talking about taking the tube out. So patient will get a set of medication 10 minutes before taking the tube out. Then the nurse and the RT will be there. They will deflate the balloon. Then they take the tube out. Then they will put the 2-liter nasal cannula on.
Okay. All right, and we've talked about several medications, morphine, Versed, Dilaudid, Ativan, Atropine. Is fentanyl anywhere on this palliative order set?
No, ma'am.
Dr. Hagris, are you familiar with the conversion rate between what would 1 milligram of morphine be as far as how many micrograms of fentanyl?
1 milligram morphine, it will be equal to, I think, 10 microgram of fentanyl.
All right, so if I go back up here, sir, I'm just going to go back to the first page. So if you're starting, let's even go with 10 milligrams of morphine. See how good you're at math. How much? I'm sorry, go ahead.
I'm sorry, it depends on the patient, you know. When I assess a patient and I see, like, you know, what's his clinical condition, what's his comorbid diseases, what's his age, what's his size, what's his body habitus, what's his tolerance to this medication, I decide which dose I will use.
Okay, so let's say you chose 10 milligrams of morphine, what would the conversion be to fentanyl?
Objection.
I understand. I'll permit it.
Thank you. Do you remember the question, Dr. Hagris?
Oh, yes. 10 milligram will be 100 mics of fentanyl.
Okay. Dr. Hagris, you're still at Mount Carmel West. Has this has this order set changed over the course of time you've worked there?
No, not to my recollection, really.
All right.
Not to my recollection.
Did they adopt or at least update the policy to your knowledge?
No, I really don't know.
Are you aware, Dr. Hagris, of, at this time, whether there's a mandatory?
Objection. He just stated he's not aware of any changes.
Have your whole question. Let's put the question on.
Certainly. And Dr. Hagris, don't answer this yet, but I'm going to put the question on the record, okay? Are you aware of whether there is currently a mandatory order set for palliative care withdrawal? And hang on a second before you answer that.
Okay, I'll permit that question.
Okay, Dr. Hagris, you can answer that if you know.
No, ma'am.
Okay.
Not to my knowledge.
Dr. Hagris, have you used that order set throughout the time period you've been with Mount Carmel?
And even before Mount Carmel, in my prior job in Atrium Medical Center, we started with Epic, and I started using order sets. So when I came to Mount Carmel, I had the mentality to use order sets. So when I came, I created all my favorite order sets for all kinds of treatments, including palliative withdrawal.
And can you estimate approximately how many palliative withdrawals you've done during your time with Mount Carmel West?
I don't have an exact number, and it's just hard to estimate, but I would say maybe 15 to 20 once a year, but it could be really wrong, so I really don't have an accurate number.
Have you always used that order set when you're doing a palliative withdrawal?
Yes, ma'am.
Have you ever had an issue with the patient while using that order set?
No, ma'am. Because the patient will get this medication every 15 minutes.
Okay.
So he will get enough of this medication, and the patient will get assessed every 15 minutes. So if the nurse has any concern, she will call me and I can adjust the dose, but it's rare to happen.
Can you think of what the maximum dosage of morphine you've ever used is in a palliative withdrawal?
Well,
Objection. This is again.
Okay. Maybe we should sidebar it real quick. Ladies and gentlemen, entertain yourselves.
Dr. Hagris, we're going up to see the judge, so just hang on for a minute, okay? Dr. Hagris?
Question.
I'm sorry.
Yes.
All right. Dr. Hagris, I believe I asked you if you had ever had a problem with a palliative withdrawal patient when you're following that order set.
No, ma'am.
All right, Dr. Hagris, I'm actually going to talk to you now about some of the patients you have treated that our case is involved with. So give me 1 second to switch files. And we're going to start with Ryan Hayes. Let me share a screen. And give it a second to come up. All right, and Dr. Hagris, this is what I have for the record marked as Exhibit 2C. And can you identify off of that the patient we are referring to?
It's Ryan Hayes, and his date of birth is 5/15/77. He was admitted on.
That was what I was going to ask you next. You're ahead of me. Does this document show what date he was admitted to Mount Carmel West?
Yeah, he was admitted on the April 2nd, 2017.
And does it show which date he was discharged, sir?
Yeah, he was discharged on the April 4th, 2017.
All right, and I'm going to skip down a second to, it's going to be page 5 of my document, so give me just a second. All right. And Dr. Hagris, I am going to refer you to this page, which I currently have up. Did you have involvement with him on Mr. Hayes on April 2nd of 2017?
Yes, he came to ICU and I saw him and I was a critical care consultation. I bought a critical care consultation at this point, yeah.
All right, and tell me what a critical care consultation means to you, please.
Means managing the patient ICU from hemodynamics standpoint, from ventilator standpoint, and managing like all kind of electrolytes abnormalities. If he needs any medication to support his blood pressure, support his heart.
And you use the word hemodynamic. Tell us what that means, please.
Hemodynamics means blood pressure, heart rate, and oxygenation. So these are all the hemodynamics that are managing these patients in the ICU.
Okay, and I'm going to scroll down the page here a little bit to the next page. Can you tell us why you were seeing Ryan Hayes at this time, as far as what his circumstances were?
Well, the patient presented to our emergency room because of cardiac arrest. He has IV drug abuse history. His sister found him in the bathroom, and he was pulseless. So she called EMS that they start resuscitating him, and he got 5 runs of CPR along with medications and shocking. Then he came to our ER. His blood pressure was low, so they started him on a pressor medication called Levofit to bring up his blood pressure, and they give him a bicarbonate, and of course he was intubated. I didn't put this in my note, but I assume he was intubated. So I talked to his sister in the waiting area, and I showed to her what I found in his CAT scan, and she agreed.
Dr. Hagris, I'm going to stop you for a second. There was an objection.
He said,
Okay.
I assume he was intubated. I think we need to make sure.
I think I'm fine with striking that part at the moment. I'm sure we'll get to that as we go further down.
Disregard his assumption.
All right, go ahead. I'm sorry, Dr. Hagros. Go ahead with what else you found at that time.
And the CAT scan of his head, I explained the findings of the CAT scan of the head to her, and she agreed that she agreed to change his code status to do not resuscitate CC arrests, which means the patient will receive full treatment. Patient will get all kinds of treatment, but in case his heart stops, I'm not going to do any resuscitation and let him go in peace.
Okay, so that's the difference between the DNRCC arrest and the DNRCC?
Yes, ma'am.
Okay. All right, I'm going to scroll down a little further. I want to talk a little bit about this general area. What does that mean to us?
General area means what is vital signs, when the patient comes to ICU, and so I reviewed all these vital signs. Vital signs means blood pressure, heart rate, oxygenation.
When I look at the I section, what does that mean to us, pupil dilated fixed?
Means really, it could be early because he has a cardiac arrest, and some patient will have this dilated fixed pupils that it can be reactive later on, or he will have, because of his cardiac arrest, he could have severe brain injury, and this is reflected in his pupils with a dilated fixed nature.
All right, and what about the neurological finding?
Yeah, when I have any patient comes as a cardiac arrest, I need to assess him if he has any response to verbal or painful stimuli, and I also assess him to have any coronary reflexes, because these are signs of a brain injury. Okay, so one important factor when any cardiac arrest comes to ICU, I need to see if he has any brain injury or not, because this is the most prognostic factor. And these are all signs I'm looking for in my exam.
And what did you find regarding Mr. Hayes, sir?
He was not responding to any verbal or painful stimuli, and he has no coronary reflexes.
What does that tell you as the doctor?
Tells me he has some sort of brain injury.
And when you say not responding to painful stimuli, what does that mean to us as lay people?
Well, when I try to squeeze his shoulder, he doesn't grimace.
So would I be correct in saying he's not feeling pain at that point?
Objection. Again, asking.
Yeah, I think we're getting that close there. Let's rephrase the question.
So what does that mean about Mr. Hayes' ability at this point to feel any pain?
Again, it's the opinion she sees.
Well, rephrase the question, okay?
So Dr. Hagros, what does that tell us, not responding to painful stimuli?
Again.
Hold on. This means from my, I'm sorry, should I?
I got my mic off. Okay, doctor, when you see that in your performance of your duties, what does that mean to you?
This means to me that this patient will have, most likely he has some sort of brain injury.
Okay. All right, and I'm going to scroll down a little bit further. Did you reach a diagnosis?
Yes, I put in my assessment plan, he has a cardiac arrest, most likely due to drug overdose.
And what is your goal with him at this time?
My goal with him at this time is to just support him, and neurologists should come to see him next day and the CAT scan also showed he has a diffuse brain edema.
And what
So
does that
brain
mean?
edema, means it's a diffuse brain swelling, and this is a one of the 4 signs when a patient of cardiac arrest comes to a hospital. Means because our brain cells cannot sustain more than 5 minutes or 10 minutes max without a good blood perfusion. After this, the brain cells will die and will swell, will cause this brain swelling. And when a patient has a diffuse brain swelling, this is a really poor sign of survival. And so at this point, I was supporting him. He was intubated.
Okay, hold on,
And
Doc.
Hold on a
Hold
second,
on.
Yes.
Dr. Hagris, there's an objection.
Okay.
He's getting across the line. I sustain.
Sure.
Let's ask him a new question.
All right, I'm going to move on, Dr. Hagris. I want to go down to page 13 for a second.
Okay.
All right, and I want to direct your attention to, hang on, I got to go up just a little bit, hang on. All right, I want to talk about this top, and it's labeled order. Can you explain to us what this is?
It's a palliative care consultation. And this is when a patient with cardiac arrest comes, I put an order for palliative care consultation, especially with a poor outcome.
And when you say palliative care consultation, what does that mean you're actually doing?
It's a consultation to the palliative care physician, Dr. Phillips St. Emma, and to come and be involved in the discussion with the family to address the goal of care.
And you placed that after the consultation with Mr. Hayes?
Yes, ma'am.
Then I want to go down to page 15 for you for a minute. And again, it's an order, but I'm going down to the bottom one. Tell me about this order, the Dnrcc arrest. Tell me about that, please.
Well, when I talked to his sister and I showed to her the CAT scan finding, she agreed that, this is a poor sign, so I changed his code status I didn't change. I placed an order to make his code status do not resuscitate arrest. And do not resuscitate arrest means he will get a full treatment, but if his heart stops, we let him go in peace.
All right, and why do you place this order in Mr. Hayes's EMR, his electrical medical records?
Because his CAT scan of the head findings, of the diffuse brain edema, most likely he will have anoxic brain injury, means that he has more than 10 minutes deprivation of blood supply to his brain, and he will have a poor outcome. So in this case, it's not really recommended to do resuscitation again if his heart stops. So for this, I put this order in.
All right, and when you leave for the night, I should say, not the day, does this notify every other person who's involved with him that this is what his code status is?
Yes, ma'am.
All right, I am going to switch to what I've labeled as 3B regarding Beverly Schertzinger, and let me get to that record, sir. All right, and I'm going to go down. All right, and before I go anywhere, can you tell us which patient this is regarding? Hang on, let me share screen. Forgot that step. All right, and Dr. Hagros, can you tell us which patient this is regarding?
Yeah, it's Beverly Schertzinger.
And what's her date of birth, sir?
It's October 17th, 1953.
And what is her admit and discharge date, sir?
October 2nd, 2017, and the short date is October 9th, 2017.
All right, and I'm going to go down to page 20 for your sake to get through to where you're at. All right. And can you tell us what you're doing at this point with Ms. Schertzinger?
Most likely she came on my shifts, and I was a critical care consulting physician, and I saw her when she came to ICU.
All right, and I'm going to scroll down for you. Can you tell us why she came into ICU?
She is a 63-year-old lady. She came to ICU because she has some productive cough, and her PCP, she visited her PCP, but nothing been done. So she came to our Grove City ER, and they performed a CAT scan for chest, and they showed she has a cancer, most likely a cancer in her left lung, and she was. This is why she came to ICU. Her sodium was low. Her sodium hyponatremic. Hyponatremic means her sodium was low, and per our hospital policy, if any sodium less than 120 has to come to ICU, because these patients are prone to have seizures.
Okay.
So she came to us, to ICU.
All right. I'm going to go down a little bit. And just kind of following along the same thing we did with Mr. Hayes, tell us about her general condition that you looked at that time.
My exam for her was general. She was reviewed all her vital signs. Her eyes were fine, mouth was fine, respiration was fine, cardiovascular was fine, GI was fine, neuro was fine. So yeah, so her exam was benign. Yeah.
Did you give her a diagnosis at that time?
Yes, her main diagnosis that brought her to ICU is acute hyponatremia, mean acute low sodium.
Okay. And what were you looking at as far as treatment at that point when she's in the ICU with you?
My main goal is to bring up her sodium to the safe range. So because of her new diagnosis of lung cancer or lung mass, so this is a condition called SIDH that cause low sodium. For this, I needed to restrict her fluids to bring up her sodium and follow blood work every 6 hours. And in the same time, I wanted to work up her cancer to see if it is spread anywhere else. So I sent her for other CAT scan of her head, abdomen, and pelvis. And I consulted oncology team to follow on that.
All right. And I'm going to go forward to page 53. And I just want to talk very briefly about this order. Can you tell us what was ordered at this time for Ms. Schertzinger?
This order for severe pain, it's as needed order, and I order morphine 2 milligram IV push every 2 hours for severe pain scale. Yeah.
And IV push, what does that mean to us?
IV push means like it's a syringe, like maybe 10 cc or 5 cc syringe, and the nurse will, like, will get it from the vial and push it to the patient when patient requires pain control.
And do you remember, while you were treating Ms. Schertzinger, did those 2 milligrams help her pain?
No, I don't remember.
Okay, that's fair. All right. I'm going to switch to Mr. James Allen. Hold on just a minute. And this is what I've marked for identification as State's Exhibit 8B. Dr. Haggard, can you identify the patient for us?
James G. Allen, his date of birth is 5/29/37.
And what was his admit and discharge date, sir?
He was admitted on May 24th, 2018. Discharge date is May 28th, 2018.
All right, now I'm going to go forward to page 5 and 6. Dr. Hagris, can you tell us what you're doing here? What is your involvement with Mr. Allen?
I was putting a vascular access. It's either a central line. It's a long IV access. Go to the one of our main veins, and this will give us a good access to give him all kinds of medications. At the same time, if I need any blood work, or we can just take it from this line. Or I was putting an arterial line. Arterial line, it goes to one of our arteries here in the hand to just monitor his hemodynamics.
Okay.
So it's not clear here in this page which procedure I placed for him.
All right, let me go down and see if that clears it up.
Okay, so it's a central line.
Okay.
It's a central venous line, yes. So I placed a central venous line in the right internal jugular vein.
Any issues with that procedure?
No.
And what was Mr. Allen's diagnosis that he was in the ICU for at this point?
I can't tell from this document really. But here, it's here. Diagnosis septic shock. Yes, here. Septic shock. Septic shock means patient has severe infection that caused him to have a low blood pressure.
Okay.
In this case, the patient will need antibiotics, we need a medication to bring up his blood pressure. And in this case, I need to place a central line to infuse safely these medication.
Okay. All right, and I'm going to switch now to Sandra Castle.
Sandra M. Castle, okay.
And what was her admit and discharge date, sir?
Admit was November 10th, 2018. Discharge date is November 13th, 2018.
All right, and I'm going to advance to page 7 for you. And can you tell us what your involvement with Ms. Castle is at this point?
I think I'm the one that I admitted her to ICU, or I saw her when she came to ICU, and I put the critical care consultation.
Okay. And why was she in the ICU with you?
She came because her husband found her unresponsive, and I'm sorry,
I
could
went
you
past
scroll
it.
up a little? Yeah. And okay, and she has a cardiac arrest, and her son started the CPR. EMS was called, and they took over, and she was in BFib arrest. So she was in cardiac arrest, and she got shocked by EMS, and they give her a medication called amiodarone, and she got intubated, and her pulse came back, and they started her on a pressor medication, Levofit. When she came to ICU, she was moving, but not purposeful. And I cooled her down in the ICU, and I did talk to her family in the waiting area and updated them about the plan of care.
Okay. And along the same lines as we've talked about with your other consultations, what did you find as far as her general vitals?
Well, I reviewed all her vital signs when she came to ICU, and her pupils were reactive, and I didn't see anything in her mouth or respiration. Could you scroll down, please?
Yes.
Otherwise, I didn't see any abnormal cardiovascular or,
And what was her general condition then as she was admitted to the ICU?
She was critical, in very critical condition.
Okay. I want to talk about, you indicated she was intubated. What does that mean to us?
This means the patient cannot maintain her own breathing. So she got a tube down her throat, and she's hooked to a ventilator to do the work for her.
And I note here you actually use Versed and fentanyl together. Why would you use that medication at this point?
This is a very common practice to start this medication while the patient is intubated, because the tube itself is irritant. Okay, so it will cause a gag and cough. So I need to keep the patient comfortable, and I want the patient to work with the machine. For this, he has to be under sedation.
And I'm going to go forward to page 73 first. And Dr. Husel, I want to talk about this order here, full resuscitation. What does that mean to us? Dr.
By the way, I'm
Haggis.
Dr. Haggis. Yes.
Sorry.
Yeah. So full resuscitation means it's a full treatment. Patient will get a full treatment, and if his heart stops, I'm going to do a resuscitation, give him all kind of medication to bring him back.
Okay. And going forward a little bit further to some of your your orders. Dr. Hagris, I want to talk about this order here for fentanyl. Can you tell us about how much fentanyl and why you're ordering it at this point?
This is because she's intubated, so I need to keep her under sedation. So if she needs a breakthrough pain control, I'm providing her with 50 mic of IV push every 1 hour as needed.
Okay, so
And the RAS score at this point was -1 to +1.
all right, so tell me what a RAS score is. Because we haven't heard that
It's
one
called
before.
it's a Richmond agitation sedation score, and it goes up to +3 to -5, and this score like mainly we keep the patient +1 to -1, and this score the nurse will render every maybe 1 hour to be sure the patient will meet the score. And this score, what's the goal is just to keep the patient comfortable and synchronous with the vent, because I want the ventilator to work for the patient. So I want him to be on this like sweet spot, so he would be comfortable and the ventilator will work for him.
All right, and you ordered 50 micrograms IV push inject. Tell me how that's going to be administered so we understand this.
Well, I put the order in. The order will go to the pharmacy to verify it, and they will send it to the nurse. The nurse will get the vial, will take the medication and push it to the patient if the RAS score is still not maintained.
And this was something that would maintain them, is what you said, as far as patient while they're on the ventilator?
Yes, ma'am. Yeah.
Going on to the next page in this order. Fentanyl additive 2,000 micrograms. Can you explain what that is to us?
This is an infusion medicine, and this is also a common practice. My practice is a patient has a tube down his throat, he's intubated. I want to keep him in a good RAS score, so support him. So I will start fentanyl infusion to be sure the RAS score will be maintained like 24 hours. So I start him on I start her on fentanyl infusion. The range is 25 to 500 mics per hour. So they start 25 and they titrate up to achieve the RAS score. And the RAS score is the same here, -1 to +1.
25 to 500 an hour, so that's going to be for an entire hour time period?
Yes, ma'am. 25, we start 25, and the maximum is 500 mics per hour.
Is 500 mics per hour high?
Objection.
Sustained.
What would determine how much fentanyl that Ms. Castle will get each hour?
I'm sorry, say it again, repeat it, please.
No, it's not the same thing. Doctor, when you made this
Yes.
order, okay?
I'm sorry, I can't hear. Can you?
I've got my mic off because of the echo. When you made this order, why did you put that amount of fentanyl to be distributed to her?
Well, it depends. We start 25 mics per hour. Then the nurse will assess the RAS score. And you can see here, it's a titration, titration medicine. So she will titrate up till she gets the RAS score -1 to +1. And this is where the patient will stay on.
All right, Dr. Hagris, here, let's talk about this order also.
This is also a common practice is to start a sedation. So the patient, when the patient comes like, a critical ill patient, and he's intubated or she's intubated, I need to keep the patient on 2 infusion medicine on analgesia and sedation. So analgesia will be provided with a fentanyl, and the sedation will be provided with Versed. Plus, I'm cooling the patient down. I'm putting the patient under a cooling blanket to bring down her temperature, and this is very discomforting. So I need to be sure that she gets enough sedation. So I started Versed infusion, which is 50 milligram on the bag of normoxidine. It's a 2 milligram per hour, and the RASS score is the same, -1 to +1.
So did I hear correctly, 2 milligrams per hour?
Yes, ma'am. Yeah.
All right.
Yes.
And you had just said this is very common when they're intubated. Can you explain that to me?
When patients intubated, I need the patient to be in a good, comfortable, spot, and the machine will work for him. Plus, this patient also, I cooled this patient down. So her temperature, I'm going to drop her temperature to 34 Celsius. So, and this is very discomforting. So, I need to keep her under good sedation. So she will not shiver. She will not really be agitated. So, and this is a common practice in these cases. Yeah.
All right, and you said something that, you said because the ventilator will work for her. What do you mean by that?
Well, I need to be sure the patient will be synchronous with the vent, because sometimes when the patient is not under enough sedation, the patient will cough, the patient will fight the vent, and the vent will keep alarming. So in this case, this means the patient needs more sedation. So in these cases, I need to keep the patient under enough sedation so the vent will work for the patient till I fix the problem in the patient.
Okay. All right, and Dr. Hagris, I'd like to talk to you about this order from the NASDAQ, Versed. Can you tell us about this?
Yeah, this is for the breakthrough agitation, like the breakthrough pain for fentanyl. I put a Versed. It's a 2 milligram injection every 15 minutes if the patient needs it, and to get the RASS score under control. But this is mainly. This is not mainly for the RASS score. This is mainly for agitation.
Okay, explain that to me.
A patient gets agitated and she is coughing, she is fighting the vent. In these cases, we give this medication to keep the patient synchronous with the vent.
Okay, and here you're using 2 milligrams, I'm sorry?
2 milligram IV every 15 minutes, yes.
Okay. All right, and I want to switch over then to the last patient you were involved with, which would be Rebecca Walls. And Dr. Hagris, can you tell us who these records are regarding which patient?
That's Rebecca A. Walls, and her date of birth is July 7th, 1943. She was admitted on November 13th, 2018, and discharged on November 19th, 2018.
All right, I'm gonna move down. To page 2 here. Can you tell us what your involvement with is with Ms. Walls at this point?
She came to ICU in my shifts, and I saw her ICU and put a critical care consultation.
And why was she coming to see you at the ICU at this point, sir?
She came to ICU, she had a cardiac catheterization, and she had a complication with a groin hematoma. Patient was in PACU for 15 minutes with the pressure applied to the groin to stop the bleeding. And she came to ICU because her blood pressure dropped and she became altered. But in ICU, she was more arousable. She gave me all her answers, and I found also her carbon dioxide was high, so I placed her on BiPAP, and vascular team was consulted instead because of her because of her groin hematoma.
All right, hematoma, what is that to us lay people?
It's a blood collection under the skin.
And BiPAP, what is that?
BiPAP, it's a pressure mask. Okay, it applies two kinds of pressure. It's something like when, sleep apnea when patients sleep on a CPAP machine. This is like this, it's a pressure mask, provide pressure and oxygen for the patient.
And as we've talked about with the others, what was her general condition then at that point in regards to her vitals?
Well, in my exam, I reviewed her vital signs. Everything seems to be normal except her extensive right groin hematoma, and it went down to it extended to her midline of her right leg. Otherwise, she was alert, oriented, time 3, yeah. So everything was benign except her right groin.
Okay. And as far as any other information that would be relevant or that you found relevant at that time?
No, CT, I sent it for...
Object. Hold on, Dr. Hagris.
The question
Okay.
is okay, but clearly you need to, let's rephrase the question.
Sure, absolutely, sir. Her general condition at that time, other than what you've told us, was there anything else that was important to you as the treating physician at that point?
At this point, I wanted to send her for CAT scan, just to be sure there's no bleeding in her abdomen, like behind, like something called retroperitoneal. It's a part of our abdomen. And at the same time, her pressure was still low. So I started her on IV pressor medication called Levofed. And I placed a central line for her, and I give her 1 unit of blood. So she was in fairly critical condition because she was in Levofed. She required blood transfusion, and I was looking for the CAT scan finding also, yeah.
All right, and you've said the term pressors a few times. What is that to us?
Pressor, it's a medication when the patient has a low blood pressure. This medicine, what it does, it constricts our artery to bring up the blood pressure.
Okay.
The main agent that we use in ICU called Levofed, which is a norepinephrine.
Okay. And I'm going to go forward to page 67. Okay, and in case, I don't know that I said this for the record, this is what's labeled States Exhibit 13C. I want to direct your attention at this time to the order in the middle of the page there, midazolam. Can you tell us about that?
I order Versed midazolam. It's not clear here how many milligram.
Okay.
It's IV push, but for some reason it doesn't tell us how many milligram was the order.
Okay, let me go forward then and see if we can get anything else. All right, so let's talk about the fentanyl. Can you tell us about that?
Yeah, I order here it's a 50 mic, but it doesn't specify how frequent. Is it one time or what? It's not clear in this order, but I order 50 microgram of fentanyl.
Hang on just a second, Dr. Hagris. Maybe I can simplify this. Just a minute, Dr. Hagris.
Sure, take your time.
All right, just a few follow-up questions, Dr. Hagris. You indicated your shift. What days did you work at Mount Carmel West?
What days?
Correct. Or nights, I'm sorry.
What nights? So I work, me and Husel, we used to split the week, so I come and I work 4 nights. Then he will come to cover 3 nights. Then the week after, I come and cover 3 nights, and he will do 4 nights.
Okay. And were there specific nights you worked as far as days of the week, nights of the week?
Yeah, I remember I had specific nights, but I really don't, I don't remember the exact dates right now. I remember that we were alternating Saturday nights.
Okay.
But I don't remember, yeah.
Okay, that's fair. When you were describing the BiPAP, you referred to CPAP. What is CPAP to us?
CPAP, CPAP is a machine. Patient has sleep apnea. He sleeps on to keep the pressure on oxygen. But the BiPAP is more, it gives more pressure. It gives 2 pressure. And this is what we use in the hospital.
Okay. Do you know what the CPOT is? CPOT.
Well, it's a pain scale, but it's more nursing business. You know, I don't use it really.
Okay. Dr. Hagris, we've seen how you've used the fentanyl over the course of, I think you called it titration, so many micrograms per hour, depending on the score. The RAS score was how you had it in those. Have you ever given one?
Okay, there's an objection, it's premature, overruled for now. Finish the question.
1,000 micrograms of fentanyl as an IV push? And wait a second before you answer that.
Okay, overruled. You
Okay.
can answer that question.
You can answer that question, Dr. Hagris.
No, ma'am, I did not.
Okay. No further questions, Your Honor. Dr. Hagris, we're going to have to do some logistics and switch the computers out so Mr.
Okay.
Baez can ask questions, so hang on a minute, okay?
Can I do my job?
I'm sorry, sir.
Okay. I need to give my court reporter a break. We've been going at it an hour and a half. Okay, so we're gonna take 15 minutes. We'll get all organized. You can stretch your legs, walk around, get comfortable, get a
Okay.
cup of coffee, whatever you want, and then we'll be back
15
in
minutes?
15 minutes. Ladies and gentlemen, I'm
Thanks,
gonna
sir.
send you on break for 15. Remember the admonitions.
I'm gonna leave them all here.
Hopefully we don't lose the contact, because he just shut us off. Is there anything for the record, Ms. Swanson? Anything for the record? Well, let the jurors get out here first. Anything for the record?
No, Your Honor.
Mr. Baez?
Jose, anything for the record?
Okay.
We're gonna figure this
We're
out.
in recess, you guys can get set up. Mr. Kirschman, do you need to see me? Okay.
Do you
Yes, sir.
guys have the Zoom link? That's probably where we have to start.
Sawyer, I know.
Yes.
I
All right,
got it
hang on a
right
second. I'm
early.
gonna get into my email.
I apologize. I don't know why I want to call you Swanson.
That's okay. I think I worked at Stark County for 7 years, and about my 4th year in, somebody called and said, "Is there an S on the end of your last name?" I'm like, "It took you 4 years." All right, let me find the Zoom link. Ah, awesome. All right, well, that's not gonna help me. Let's see what I can do here. Forward. We're working on it. Okay. Yeah.
I need to set up my coaster.
Okay, I'll move my water bottle for you. What is this at? Zoom, forward.
I go to the restroom while you guys.
Meeting, file, help, it's not a, here we go, I need this one, hang on just a second. So I need, hey Taylor, can you spec that, I can't forward a forward. Can you send the Zoom link over to Allison? All right, yeah, that's my problem, I can't forward a forward, so it's gotta come from you. You have the original link, it's gotta come from you.
Yeah, well, I think there's some, but I think there's some.
There are actually 14 screens going on.
Keep it simple. Oh, yeah, the code sheet too.
Okay, which one's in order so I can set it up for him? Do you have an order or just all of them open?
Just have them all open. And then tell me what okay.
Hold on,
Yeah,
give me
yeah,
2 seconds
that'd
so I
be
can
perfect.
just pull them up. Okay, well, they're not even here right now.
Is it, if you have to be here, so maybe I'll move over here to kind of keep it focus on that. Yeah, I think that's probably the way to go.
Look at, I guess. This one comes in.
I'm in. Well, let me tell you. Yes, yes.
question.
But I knew you were right behind me, so what
Yeah, well,
difference would it make? But let me tell you what happened. And this is just between you and I. I closed 3 systems.
Yeah.
And a single mother. They used to whoop my ass.
Okay.
That thing. I mean, whoop it.
Yeah.
Okay? And one day,
Make sure
I
your,
grew a set of,
My thing's off.
your speakers are off and your
and then when I became
microphone's
single,
off.
Got it.
I rebelled.
And then
And literally,
check your ability to
everyone
share
who's ever been
screen.
with me
When I get the
afterwards
next
has had
one.
to deal with
Okay.
it. It's just regular fuse.
It's just
Because
regular.
I know
Yeah, so let me know
I'm
if there's
finally
any
a
issues.
grown man and I can leave it up whatever the hell.
It's all good.
But in fairness, I knew you were right behind me.
That's fair.
So,
I grew up with 4 brothers, so
okay.
we didn't have a lot of problems there, and Mom knew to look.
So it's a hilarious little soft or sore spot for me.
This shirt's in good there.
For any order you're going to go, or just be ready for anything? Yeah, be ready for anything. I'll tell you which one.
Is he your tech support?
Yes,
Yes.
yes. You don't want me back there. Oh, no.
I'm getting there, Doc. Relax.
This way you need me out of the way too if you got to sit down.
Call it.
All rise. Thank you. Please be seated.
Ladies and gentlemen, I hope you had a good break. We're going to continue on. Mr. Baez, doctor, remember, you're still under oath.
May it please the board.
Yes, sir.
Prosecutor. Good morning, ladies and gentlemen. Good morning. Good morning, Dr. Hagris. Or shall I say good
Good
evening?
morning. Well, good evening. You're right. Good evening.
All right.
For me.
Well, okay. Well, good evening to you, sir. I'm going to try and go chronologically on a few things. And this is my first time doing something like this, so please bear with me, okay?
Sure.
Okay, you testified that your first day of working at Mount Carmel, you were given a couple of hours of orientation, is that correct?
3-4 hours. Yeah, I don't remember exactly, but yeah, few hours. Yeah.
Now, after that, you then had a small IT session, correct?
Small what?
IT, like a technical session about how the
Oh,
system works.
yeah. I think it was before that I had an IT in the physician lounge. I think it's like for also a few hours with other physician. But before my IC orientation, I had the IT orientation.
Okay, and Dr. Hagris, it was the Mount Carmel job, your first job out of medical school?
No, sir. I did 3.5 years in Atrium Medical Center. I was inpatient hospitalist. Then I was promoted to be a medical director of the hospitalist group in Atrium Medical Center. Then I came to Mount Carmel.
Okay, so you had prior work experience after having your residency and all of your other training, correct?
I had what?
Other hospital experience?
Yes, yes, sir.
Okay.
Yes.
And after...
Mr. Baez, you're getting away from the mic,
Sure.
and that's what's part of this problem.
Okay. Can you hear me okay here?
Yes,
Okay.
that's perfect.
If you can't hear me, please just raise your hand and I'll make sure I adjust. So, sir, after, I guess, these few hours of training, you were then placed to work in the evening shift at Mount Carmel, correct?
Correct.
And you were the only doctor there in charge of 30 beds, is that correct?
Yes.
Okay. But you work with a big team. Wouldn't that be fair to say?
Yeah, I used to have a resident in the beginning. I think in the first 4 years, I used to have a resident work with me overnight. And of course, I have the charge nurse and the nurses.
Okay, and the residence is basically a doctor in training, right?
Yes.
Okay, so you're kind of training this doctor on how to do things.
Yes, yeah, I was his backup. If he needs anything, if he has any questions, if he wants me to supervise any procedure, I will be his attending doctor.
But as far as the medical decisions to be made, the buck stopped with you as it related to these 30 beds when you're on your shift, right?
Well, if the residents, there used to be two kind of patients come to ICU. A patient with insurance will go to a hospitalist, CIC, and this is where I will manage this patient. And patient without insurance will go to a mid-clinic resident, and he will make decisions. And if he has any questions, he will come to me. But also he was in the capacity to make decisions for these patients.
Okay, and when you said that was at the very beginning of your employment. Was that before Dr. Husel was working there?
Yes, it was before he came. He came August, and when I came, there was a resident always overnight, and this resident overnight stayed, I think, for the first 4 years of my employment.
And Dr. Hagris, you had different training. Your specialty was internal medicine, correct?
Correct.
So that would make you an internist?
Internist, yes. Hospitalist, yes.
And that is different than Dr. Husel's training, correct?
Dr. Husel, he has a fellowship in anesthesia critical care, so he got internal medicine, then he went to fellowship, so it's different, yeah.
And you're aware that Dr. Husel was trained in anesthesiology, correct?
Correct.
Okay, so those are two completely different fields, right?
Not entirely, because the anesthesia, in the anesthesia also they will have internal medicine training, because to apply the anesthesia, you have to understand the physiology and pathology and all kind of diseases, so they can apply the anesthesia science. So it's related, but it's not different, no.
Well, I'm not saying that they don't overlap. What I'm saying
Yes.
is that they're completely different. So for example,
Objection, Your Honor, he's testifying.
I was about to ask him.
Well, I'll let you have the question. Go ahead.
So for example, an anesthesiologist has more training in the areas of sedation, correct?
Yes, in the OR, yes.
Okay.
It's most likely in the OR.
Okay, and that would involve drugs such as fentanyl.
Correct.
And it's fair to say that an anesthesiologist is more comfortable and has more experience working with a drug like fentanyl.
Okay,
But in,
sustained. Let's do a little sidebar if you want.
I'm sorry, should I answer or not?
No,
You
hold
can't
on.
answer it. You want to do a sidebar?
Sure,
I know you're
sure.
dying to talk to me.
So, taking apart the overlap, in medicine, there are different types of specialization. You would agree with that, correct?
Yes,
And your specialization is that of internal medicine, right?
correct.
And can you describe for us the differences between an anesthesiologist and that of a internist?
Well, internal medicine, it's a 3 year program that's it's specialized in every organ. Like, I had like 6 rotations of ICU in University of Maryland East Campus. I had a cardiac rotation. I had a GI rotation, neurology rotation, rheumatology rotation. So all kind of like topics in internal medicine. I had a rotation. Also outpatient had rotation, and I had to have a board test to be board certified in internal medicine. Anesthesia, I had of course, interaction with anesthesiologists in my training, also in my work experience. So anesthesia, they are specialized in the operating room where they put the patient that he will go to surgery under sedation. They work with different kinds of medication. They work with the surgical teams in different fields. And they also responsible for waking up the patient after surgery. And they are also responsible for the ventilator management during the surgery.
Okay, so to try and put this in simpler form, in a simpler form, and I don't want to, if I'm incorrect, please correct me, but to try and put this in a simpler form, an anesthesiologist is trained or has specialized training in management of pain. Is that correct?
No, I mean, like, we need to add first, it's OR.
Okay.
I need just to be sure. It's in the operate. Anesthesia is, this is my understanding, and this is what I have seen in anesthesiologists. They work mainly in the operating room with the surgical patients, managing different kind of medication plus ventilator management.
Okay, so they're not the ones actually doing the surgery. They're the ones there managing the medications while the surgery is going on, correct?
Correct. They are managing the sedation for patients, yeah.
Okay. And there's a whole area of specialization dealing specifically with that area of medicine, right? And that's called anesthesiology.
I'm sorry, could you rephrase the question?
Sure,
Because
sure. So there's a whole area of medicine called anesthesiology that specializes in that type of pain management, correct?
Well, see, you keep pressing on pain management. You see, anesthesia, it's not about pain management. This is my understanding. Pain management, there's a different fellowship for pain management. There is a different fellowship called palliative care for pain management. Anesthesia is primarily to manage the surgical patients in the operating room to keep the patient under sedation while the surgery is done and managing the ventilator. I have no knowledge that the anesthesia is connected to pain management. This connection, I'm not aware about this.
Okay, I think it was a poorly asked question because I didn't want to imply that it was limited to that. There's obviously other areas that an anesthesiologist does. Let me try this. Fair to say, Dr. Hagris, that equally trained doctors with the same exact backgrounds can have difference of opinions on various aspects of medicine, correct?
Yes.
Okay, and in fact, that's why many people get second opinions when it comes to doctors, right?
Correct.
because one doctor may be more comfortable doing things one way, and another doctor may be comfortable doing things another way, correct?
Correct.
Now, in light of that, and then that also takes into consideration what we as lay people may be considering a good doctor versus someone that's not as skilled.
Objection.
I'll permit the question.
You can answer.
Do you understand the question?
Yes, I understand. Yeah. Well, it's in medical field, as you said, every doctor has its own, comfortable, level and comfortable medication that you use. And judging doctor by doctor, I don't think, this is fair.
And you don't think it's fair because each doctor's experiences are also different, right?
Yes.
And that's because so much of medicine is patient-specific, right?
Yes.
Now, in light of that, Dr. Hagris, when you got trained at Mount Carmel when you first started, were you trained in anything that goes on at the pharmacy?
Goes to what? Pharmacy?
Yes. Were you trained in anything having to do with the pharmacy?
No, sir. No.
Okay. Were you trained as to every single thing that a nurse does at Mount Carmel?
No.
Were you trained on the Pyxis machine?
No.
Did you have access to the Pyxis machine?
No.
So could you ever go up to the Pyxis machine and put your fingerprint there and it would open up a drawer?
Well, I never tried. I never tried, so I think it won't work, no.
Okay.
Because the only two people, I'm sorry, the only two people I have seen going to the Pyxis and get medication or put medication in is the nurses and pharmacists.
Okay. So when you, fair to say you had the same exact position as Dr. Husel, correct?
Yes, sir.
Okay. Now, you just work different nights, right?
Yes.
Okay. So, in light of this, you're familiar with how things work at Mount Carmel, correct? In the ICU.
Yes.
Okay. Now, having said that, when it relates to medications, you either give a verbal order or enter in a written order, correct?
Correct.
And as far as you know, the medication gets administered, right?
Yes.
And that essentially is the end of your involvement, unless it needs to be addressed later, correct?
Not really. I mean, it's like if I give any medicine, like for example, if I give a patient has high blood pressure and I order blood pressure medicine IV, and and I give this medicine, I put it in, I will follow up with the nurse to be sure the goal is achieved.
I meant.
So there's some follow up.
I apologize for the poorly asked question. I meant as far as it getting administered. So.
Oh yeah, that's it.
That's it, right?
Yes.
So, for example, you give as a doctor a order to a nurse. That nurse will either input the order if you didn't do it yourself, and then at that point, as it relates to up until the point where it gets given to the patient, you have no further involvement, right?
Correct.
Now, as far as you're aware, at this stage, if it's a medication, at this stage, it goes to pharmacy for approval, correct?
Yes.
Okay. And if pharmacy approves it, you have no idea. All you know is it gets administered, correct?
Yes.
Now, if you see that it's administered, is it your belief that pharmacy approved it?
Yes. In my practice, yes.
Okay. If it's not administered, and what would happen? If it's not, let me rephrase it, that's a poorly asked question. If it's rejected by the pharmacist, how are you made aware of this?
Well, the pharmacist will call me to ask me, like, for example, if I bought an antibiotics and a patient has a kidney failure and the antibiotic dosage should be adjusted. So the pharmacist will call me and he will say, I need to adjust this. Are you okay with that? And I said, okay, do it please and put it under my name. And he will put it under my name and he will adjust the dose and he will send it to the nurse.
So I'm clear, so we're all clear. The only way you're ever notified if there's an issue with your dosage
Okay, you're away from the mic.
is if the pharmacy comes to you and talks to you, correct?
Well, he will call me. Yeah, most likely he will call me on my hospital phone and he will talk to me, yes.
Okay. Now, in addition to that, but prior to going to pharmacy, if a nurse has an issue with your dose, he or she can also bring that to your attention, correct?
A nurse? Well, in my practice, I don't recall a nurse came to me and told me that I'm not comfortable with this dose. But they have the capacity to do that, but I didn't have this experience.
That's what I'm asking. I'm speaking in general terms here. It's your understanding, sir, that the nurses, they're not just robots, right? They have their own independent medical judgment, correct?
Correct.
And that's a part of the process, right?
Yes.
So if a nurse took issue with any of your doses, they have the ability to, and it's your understanding, they have a duty to speak up, right?
Correct.
And at that point, the only way you're advised, if a nurse has an issue with any of your orders, is if she either speaks to you about it, correct?
Yes.
Or perhaps she goes to a manager, like a nurse manager or the charge nurse, and they speak to you about it, correct?
Yes.
And in fact, there are multiple ways that these things can be done, correct? And let me give you a couple of examples before you answer. One, they can speak to you directly. Two, they can go to the charge nurse. Three, they can go to the nurse manager. All of those are correct, right?
You just asked that.
Yes.
I was summing them up, Judge. And in addition to that, you talked about a voice report earlier in your direct examination, correct?
Yes.
That's
Yes.
another way you could discover whether someone has an issue with your doses, correct?
Yes, sir.
Okay. Are you ever notified any other way other than the pharmacist calling you that an order has been rejected by the pharmacy?
No, I mean, this is the only way, and the term rejected really, it's not clear in my ears, because I never had this before, but yeah, the pharmacists always call me. They always call me if they have any, like drug interaction. If they have any concern about anything, they will call me immediately.
And that's something as a doctor that you rely on, right? If there's some kind of drug interaction or an issue with the drug, that the pharmacist will tell you about it, right?
Yes, sir.
Okay? And you rely on that daily for your job.
I'm sorry, could you get close to the mic?
Sure. And you rely on that daily for your job, to do your job correctly?
Yes, yes.
Okay.
Pharmacy is very important, yeah.
Now, are you ever aware whether a medication is prospectively reviewed or retrospectively reviewed by the pharmacy?
In my practice, no.
Nobody comes and tells you this was prospectively reviewed, do they?
No, sir.
Nobody ever comes to tell you this is retrospectively reviewed, correct?
Correct.
And nobody ever comes to you and says this was simultaneously reviewed at the same time as it was administered?
No, sir. The only thing I get from the pharmacy, as I said, when I put the order and there's some, concern about dosage, antibiotic, kidney function, anything, they will call me and we'll discuss and we will adjust it and the order will be approved.
And that's not something you go actively looking to find out, is it?
Say it again, what do you mean?
Whether something is prospectively reviewed or retrospectively reviewed, that's not something that you go actively looking to find out, right?
No, I don't know even, it never happened in my practice, so I don't know how even to look for it yet.
Okay, you wouldn't know where to look and know that, right?
Yeah.
Okay, and it's not even a factor in your consideration. It's not something you do, right? It's not something you do at all in your job, is I guess the simple way of asking this.
I think there's some misconception right now. So let me clarify. So I put the order in. It's either verbal or in the system by myself. If there's any concern from the pharmacist, he will call me. He will call me and we'll discuss and we'll adjust it and it will go through. That's it. And the medicine will be sent to the nurse and she will give it to the patient. So I never had any in my practice about any of these prospective or respective review. So I have no knowledge about this.
Okay. Now, having said that, sir, you are also not aware, or let me strike that. Do you ever pay attention as to how the nurse actually retrieves the medication? Do you ever get involved in that process? I'm sorry?
No.
Okay.
No.
Do you ever find out whether the nurse received the medication after it was approved or before it was approved?
Well, in my practice, I put the order in, and the only time that I put the order in after the medication was given in emergency. So a patient has a cardiac arrest, and there's something called a code blue card. We pulled it, and we break it, and we give the medication and give it to the patient. And after doing the resuscitation, I go and I ask which medication was given, and I go to the system and I put the epinephrine, atropine, whatever was given to the patient. So this is the only time the pharmacy will approve medication after it was given. But in my practice, all the medication will be ordered by me or the verbal order, approved and given to the patient.
Now, Dr. Hagris, it's also when you don't write in the order and the nurse does it, you have no idea how they enter in the order, do you?
It comes to my inbox. It comes to my inbox as a co-sign order. So I verify the order, then sign it.
Okay. Let me see if I can ask this question a little bit better. Are you familiar with the phrase "scan to order"?
Scanned order?
Scan to order.
Yeah, this is a nursing business. I'm not really, I don't have the best knowledge about it.
Right, so let me give you an example of what I'm referring to. This one. Let's bring up this one first. Now, you recall giving discussions about Rebecca Walls. Do you recall that? I'm showing you at this time what is Exhibit 13, page 343.
Take it out.
Okay.
You gotta enlarge that. You've got just a short screen there.
Yeah.
Expand it out.
Okay.
You can also make the screen, the frame bigger.
That's what we're trying to do.
Top, middle.
Okay, let's go down to the bottom. Now, well, actually, let's stop here. You would, go back up to the top. Sorry. Okay, you would agree that this is the medication order for Rebecca Walls? Do you see that?
Yes, sir.
Okay, and you were asked about her during direct examination, right?
Yes.
And you were shown various medical records about Rebecca Walls?
Yes.
Okay, now I want to direct your attention to the bottom of the screen, specifically the order for midazolam.
Okay.
Can we
Could you
scroll that
scroll
down?
it down?
Yeah, he's going to scroll down for you, all the way down. There you go. Okay. Now, taking a look at this order, this is an order you gave, right?
Yes.
And in this order, the date is November 16th, 2018. Do you see that?
Yes.
And midazolam is a controlled substance? What is it? What is midazolam?
Yes. I'm sorry?
What is midazolam?
It's a benzodiazepine. It's a sedative medicine.
Okay, it's also called Versed, right?
Yes.
Okay, and you gave this order at this specific time, and if we could scroll up a little bit more. No, I'm sorry, scroll down. Okay, and in here, do you see whether pharmacy approved it?
No, I don't see the pharmacy. Do you see? I mean, no.
And do you see if it ever went to pharmacy?
I'm sorry?
You see, does it indicate whether it actually ever went to pharmacy, whether they even saw this medication?
No, this medicine, it's 4 milligram of midazolam. This medicine, when I use it for emergent intubation. So this was an emergency for intubation for Miss Wallace. And for this, it was given and placed and co-signed with me after giving the patient.
I understand that. But my question to you, sir, is on this record, and if you look down at the printed date and time, it was printed out December 6, 2018. Do you see
Yes.
that there? Okay.
Yes.
Do you have any indication by looking at this right now whether it actually ever went to the pharmacy at all?
No, I don't see the pharmacy name in it.
Okay. And if you look at this, you have no knowledge as to whether this controlled substance was ever reviewed at any given time, even after it was administered, correct?
Yeah, I don't see anything in the review information part, yeah.
are you familiar that this is what's called a scan to order?
I'm not sure about this term really. It's kind of like a nursing, but I heard it, but I don't have full knowledge. But I want to clarify this order when I put it in, this means it's emergency intubation.
I understand, So, in light of this, sir, you're not aware
I'm sorry?
of how, I said in light of this, you're not aware of how a nurse actually enters in the order, even in cases of emergencies, right?
Well, I will verify it, yeah, initially I won't, but after I go back to the EMR, it will come to my inbox, and I will see all these orders, and I will verify it, and if I don't feel comfortable with any of these orders, I can reject it. So you can see I co-sign this, yeah.
I understand, Dr. Hagris. What I'm asking you is about the pharmacy. Here, and correct me if I'm wrong, here you gave an order in an emergency situation, the nurse obtained the medications and gave it, and there is no indication to you whatsoever that the pharmacy ever saw this controlled substance order, correct?
Correct.
Okay. Now, I'd like to show you Exhibit 12, page 325. And I want to draw your attention to the top so we know who we're talking about. This
Sandra
is
Castle?
patient Sandra Castle. Do you see that?
Yes, sir.
And you were asked questions, quite a few questions about her in direct examination, right?
Yes.
And you were shown various medical records about Ms. Castle during direct examination, correct?
Yes.
Okay. Just for curiosity, were you given these records in advance to review before your testimony today?
Yes.
Okay, so the prosecutor told you which records she was going to ask you questions about?
They gave me the information that I got involved, and they advised me to review these records.
Okay, so they asked you to do this before coming today, correct? Or before logging on today, I should say.
We did it, our lawyer and from the hospital, the one that sent it to me, and I had to interview with a prosecutor. And the hospital lawyer sent these record to me, plus he sent it also the Columbus interview file to me.
That drug order that I just showed you, did they review that with you?
I'm sorry, say it again?
The drug order that I just showed you that did not go to pharmacy, did they review that with you?
I don't think so.
Okay. Now I want to show you this one. We already saw that it was Sandra Castle, right? You want to look at that again, or you're comfortable with that?
I'm okay, yeah.
Okay. Let's scroll down. I'd like to draw your attention to this order for fentanyl. You are the ordering physician on this one, right?
Correct.
And did you enter the order or a nurse entered it?
I ordered this.
Okay. This was
100
a
mics.
verbal order that was co-signed by you?
Let's see, oh, yes, I can see right now. Yes, yeah, it's a verbal order by Nurse Matt and co-signed later on by me.
Okay. So this nurse, I guess Matthew Misalowiak, I know I just butchered that.
Yes.
Yes. You got it? Okay. Do you show, and obviously fentanyl is a controlled substance, right?
Yes.
Do you show that this was ever reviewed by the pharmacy?
I don't see this in this paper.
Did anyone ever bring to your attention that this order for fentanyl was not reviewed by the pharmacy?
No.
In preparation for your testimony today, did the prosecutors ever bring to your attention that this order for fentanyl was never reviewed by the pharmacy?
Not to my recollection, no. I don't recall that, yeah.
Is it something that you would ever go looking for during the course of your duties as to whether this was approved by the pharmacy?
No. My responsibility is to take care of the patient, put the orders, co-sign my orders, and discussing, yeah, like, that's it, I don't review anything with the pharmacy after giving the patient medication.
Now, it's your understanding, as a doctor, an ICU doctor employed at Mount Carmel, that the pharmacy is going to review all of the orders for controlled substances that you give, correct?
I have no knowledge how the pharmacy works.
No, I'm not asking you that. I'm asking you specifically, it's your understanding that when you give an order for a controlled substance, that it's going to be reviewed by the pharmacy, right?
No, sir, I have no idea about this, I don't have an understanding, I don't have the knowledge that the pharmacy will review everything.
I don't think you're understanding my question. Let me try and rephrase it, because it might be poorly asked. You believe, when you give an order, it's your understanding and belief that when you give an order, that the pharmacy, for a controlled substance like fentanyl, that the pharmacy is going to review it, right? You rely on that.
Your Honor, I'm going to object. He's answered this question.
He has answered the question earlier in your cross.
Earlier, yeah.
Yeah.
Having seen this, sir, does this surprise you that this fentanyl order was not reviewed by the pharmacy?
Well, I need to clarify something. This is not my knowledge or job to look for if pharmacy reviewed or not reviewed my orders. So you're asking about something it's really not in my experience, not in my knowledge. So I have no comment about this really.
I completely understand, and there's nobody arguing with that here. My question, sir, is does it surprise you that you're ordering controlled substances that are never being reviewed by the pharmacy? Does that come as a surprise to you?
Objection.
Sustained.
He hasn't answered that.
I know he has. It's not about that.
Okay.
It's about our earlier discussion over here.
Understood. Dr. Hagris, okay. I think we get this point. I want to move on for a couple other things if I can. Dr. Hagris, the prosecutor during direct examination went over a series of questions for you in relation to some of the medications that you ordered in these patients. Do you recall those questions?
Yes, sir.
Okay.
Okay.
And
you got away from the mic. You noticed he was trying to get closer.
Sure. And all of the times that you gave these medications, they were while the patient was alive, correct? And not actively dying, I should say. Correct?
Well, I did a palliative withdrawal, so if patient is actively dying, I already put orders for them.
Let me see if I can clear this up. The questions that you were asked about Sandra Castle, they were not during the palliative withdrawal process of this patient, correct?
Correct. Yes,
They
sir.
were earlier in this patient's care, right?
Correct.
Okay. And you would agree palliative care is different than that the normal care of while you're trying to keep the patient alive, right?
Sure, yes.
Okay. In fact, you were at this point executing life-saving measures. You're trying to keep them alive. You're trying to make them better, right?
Correct.
Okay, so that is different than when the family decides that they want to withdraw care and take them off of the ventilator, correct?
Correct.
And in fact, it's fair to say that pain management in the living is different than pain management in the dying. Wouldn't you agree with that?
Well, pain management, I don't think it's, pain management, I use it only when the patient is alive, when I'm trying to keep the patient alive. Pain management, I don't think it's been used for in palliative withdrawal. What we use is comfort care. The term that I use in my practice is comfort care in palliative withdrawal.
That's a term you use, but in essence, when you're withdrawing someone from the ventilator, you don't want them in pain, do you?
Yeah, we do. I do a comfort care, but pain management, this term is used in the medical field in a living patient, but not in palliative withdrawal.
So my question, getting back to my original questions, all of the questions that you were asked about your medications as it related to Sandra Castle were not that dealing with palliative withdrawal, right?
Correct. Correct.
Okay. And then in addition to that, Rebecca Walls, the same thing. They were not in the context of palliative withdrawal, right?
Correct.
Okay. And when it dealt with Ryan Hayes, that was not in the context of palliative withdrawal, correct?
Correct.
And when it dealt with...
Hold on, Mr. Bias. Ladies and gentlemen of the jury, it's getting to be lunch hour. If we come back at 1, does anybody have an objection to that? We usually go 1:30, but I've got him and I don't know how many time zones away. Would that be fine with you guys?
Yes.
Okay, why don't we break until 1? Okay, you got an hour off.
Okay.
I hope you're not gonna go to bed on me.
No.
Okay?
No.
We'll be back in an hour. David?
All rise.
Okay. Okay, so we'll come back at, what time right now in US is?
It's 12 o'clock noon our time.
Okay, so it's 1
So we're
o'clock.
coming
We'll come
back
back
at
at 1 o'clock.
1, so an hour from whatever time you're at now.
Sounds good. Okay,
Okay.
sir. Thank you.
I don't know how many time zones it is.
Thank you.
You guys have a great lunch.
Thank you. Thank you.
I figured you were about ready to transition. So-
Judge, I have no problem. Thank you. I
Okay,
appreciate
anything
it.
for the record?
I didn't even know what time it was.
Miss Sawyer, anything for the record? Anything for the record?
Nothing.
Okay, we're down.
Thank you.
I saw Miss Roberts in the back. Did she go? Yeah?
Hey, Dave, come to lunch.
I figured she was here to yell at me.
Let's do lunch together.
Do we have anything for the record before we start?
No, I think we're ready.
Okay. We're bringing the jury in, doctor. Give us a second. Everything okay, Deb? Huh? There you go. We do have a happy jury. Not the happiest I've ever had, but they're up there. All rise. Ladies and gentlemen, I hope you had a good lunch. Sorry to cut it short, but I wanted to get busy. We're going to continue on with testimony. Are you ready to proceed, Mr. Bias?
Yes, sir.
Doctor, you understand you're still under oath.
Yes, sir.
Please support the prosecutor. Good afternoon, ladies and gentlemen. Good afternoon, or good evening again, doctor.
Yes, sir.
Okay, before I jump back in, I wanted to ask you a question that I forgot to ask. Can you tell the ladies and gentlemen of the jury what an attending physician is?
Attending physician is a licensed physician that he will attend certain part of the hospital, managing patient, responding to a nurse's calls, and sometimes he will also train residents.
Okay. Now, is every patient that comes into Mount Carmel assigned an attending physician?
Yes,
Okay. And that attending physician is basically, one of their responsibilities is to track the entire care even up to when they die, correct?
correct.
Okay. And if a patient passes away in the hospital, they write what's called a discharge summary, correct?
Correct.
And that discharge summary is basically an overview of the entire stay at the hospital, right?
Correct.
And part of writing that discharge summary is looking at the medical charts that kind of shows all of the care and medications that the patient received, correct?
Correct.
Okay. Now, going back to where we were before we broke for lunch, you had testified I went through various names of individuals that you testified that under direct examination, you were asked about medications you gave during the care of specific patients, living patients, correct?
Yes,
And that was while you were attempting to keep these patients alive and utilize life-saving measures, right?
correct.
Okay. So, I think I got all of them, but I know I didn't ask you about James Allen. That was also one of the patients that you reviewed with the prosecutor on direct examination, correct?
Correct.
And the care that you were giving Mr. Allen at that time was not palliative care, it was the regular care while you're, I'm sorry, ICU care, correct?
Correct.
Okay. Now, you were also asked about Beverly Schertzringer. Do you remember that?
Yes.
Okay. And I want to ask you, but I want to kind of bring time into context. Bring that up first. No, this one. Yes, I'm going to show you Exhibit 3, page 749. You would agree that on the top right-hand corner, this patient is Beverly Schertzringer? Schertzinger, correct?
Yes.
Okay. And if we can scroll down to the very bottom, do you see the date of October 9th, 2017 at 11:25 p.m.?
Your Honor, I'm going to object. I don't think this is anything that Dr. Hagris worked with as far as the patient.
Okay, well, I'll let him have the question so far.
Do you see that, sir?
Yes, I see October 9th, 2017. There's actually two of these dates, you know.
Okay.
There's
I'm
one of them.
specifically,
Okay, both can't talk at the same time. She doesn't know that.
I want to draw your attention to the nursing note on October 9th, 2017 at 11:25 p.m. Do you see that?
11:25 p.m. Yes, I see that. Yeah.
Okay. And this is basically a nurse's note that advises you that Dr. Husel spoke with the family at bedside.
Objection, Your Honor.
Rephrase.
This basically indicates what's going on with the patient at this time, correct?
Correct.
Okay.
It's up to the notes. Yeah. Yes.
So on October 9th,
No. You show the witness.
just
We're not doing a closing argument.
So we're clear, because I'm going to go back a little bit on this patient that you were asked about during direct examination. This patient was extubated.
Your Honor, can we approach?
Ladies and gentlemen, I know you haven't met your fellow jurors yet, so.
Your Honor, can we take that down since we're having a sidebar about that?
Yeah, go ahead and take it down.
right, Dr. Hagris. Bringing back up this record, this nursing progress note indicates that Ms. Schertzringer was palliatively extubated at 23:20, which is 11:20 p.m., correct?
Correct.
Now, I'd like to show you Exhibit 3, page 817. Is this the same patient? Just want to make sure. Yes, sure. No, there we go. Now, this is what is known as a code sheet, correct?
Ask him if he recognizes it,
Oh,
please.
I'm sorry. Do you recognize what this sheet is, sir?
Yeah, it's a code blue sheet, yeah.
Okay. And these are written up whenever someone has a cardiac arrest in the ICU, correct?
Correct.
Okay. Now, under physician signature, that has Dr. Husel's name, correct?
Yes.
And then on the top right-hand corner, that also has, under who intubated, has Dr. Husel, correct?
So, yeah, I'm trying
Top
to
right-hand
find it. Where is it?
The top
yes,
right-hand
I saw,
corner?
yeah, so, yes, yes,
Okay.
yes, I see it here. Yeah.
And just to clear it up, on the very bottom, it has the patient's name, correct?
Yes, I saw it, yeah.
Okay. Now, on this form, it indicates to you that at 21:56, there was a code blue cardiac arrest, correct?
Correct.
Okay, and we know from the previous exhibit, an hour and 20 minutes later, she was palliative extubated, correct?
Correct.
So this is
I
essentially...
don't remember the timing, but what was the time of palliative extubation?
Okay, there's no
21?
question. Doctor, relax for a second. There's no question pending.
Okay, let me put you back in time to where we're at. From the previous exhibit, we showed the nursing note that at 11:20, she was extubated. Do you see that? Or do you remember that?
11:20, okay.
Okay, now this is,
Okay.
if it's 9:56 p.m., this is about an hour and 20 minutes previously, correct? Approximately an hour and 20 minutes earlier.
Okay.
Okay, so you're following me with Ms. Schertzringer's care. An hour and 20 minutes before she's extubated.
Sir, could you please show me the prior exhibits?
Sure.
The prior documents, so yeah.
Sure. We're bringing up again Exhibit 3, page 749.
Let's see the date. So he said here it's 23:25. So 23:25, this is 11:25 p.m. Okay. Sounds
Okay.
good. Okay.
Now we're going back, look at it's October 9th. We're going to go back to the code sheet, which is Exhibit 3, page 817.
Okay.
So, my question is, less than an hour and a half before being extubated, she had a cardiac arrest, correct?
Yes.
Her heart stopped, right?
Yes, according to the record, yes.
Okay, and she had no blood pressure, correct?
Correct.
Okay, and it was Dr. Husel who performed CPR on her, correct?
Yes.
According to this
Here
sheet.
on the code, yes.
According to this.
Yes.
And according to this record, he did what is called 4 rounds of CPR. Is that correct?
Yes.
Before she finally had her heartbeat and a pulse returned. Correct?
Correct. Yes.
This is considered a life-saving measure?
Yes.
In fact,
Stop. Ladies and gentlemen, you disregard the last question and answer, okay? It'll make sense someday to you, but for right now, you totally disregard that.
understood, Judge, I'm following you. Okay, so also on this record, you testified during direct examination about vasopressors, or vasopressors, I guess they're pronounced tomato. Do you see an indication on the top, or I guess under the comments section, whether Ms. Schertzringer was given vasopressors at this time?
Don't see, there's, yeah, I can see it here. It's, there's a levo, patient on levo and vasopressin. Patient is intubated. So, patient was started on levofed and vasopressin. So she was started on 2 vasopressor medications.
Okay, we could take that down now. Now, as you testified in direct examination, vasopressors are a medication that's given to assist with the blood pressure
Yes.
and heart rate to basically keep the blood flowing through the body, right?
Well, levofed and vasopressin, they are, they only work on the blood pressure. They fix the blood pressure. There's other vasopressors like dopamine and dobutamine that it will increase the heart rate. But in this case, the order only for levofed and vasopressin for blood pressure management.
And in your experience as a doctor, Dr. Hagris, vasopressors are utilized, they're a form of life support, are they not?
They are.
Okay. And they're also fast-acting, correct?
Correct.
Okay. And when I say fast-acting, we're talking in terms of 1 to 2 minutes, right?
I don't know the exact number, but it's very quick.
Okay. And when someone decides in terms of palliative care, that's one of the life support measures that are taken off, correct?
Correct.
Okay. So once a vasopressor is turned off, the effects again take 1 to 2 minutes. It's fast acting. It turns off, right?
Sustained. Strike the question.
Okay. So that is, I already asked you whether when you withdraw someone's care that vasopressors are turned off, correct?
Yes.
Okay. All right. Now, I want to go back for a moment on something, and that is that when the determination is made to speak to the family about withdrawal of care. Okay, do you understand that?
Yes.
That can happen a variety of ways, correct? The conversations with families, the initiation of the conversations with families.
Do you understand the question, Doctor?
Well, I don't really.
Okay.
Okay.
Let me give you some examples of what I'm talking about.
No, it's sustained.
You can have a conversation about withdrawal of care if the patient's family either comes to the nurse or comes to you to discuss this, correct?
Not in my practice, really. The common scenario in my practice is a patient has been in the ICU for quite time, and there was ongoing discussion with the family because the patient prognosis is not promising. And the two scenarios that it happens in my practice, it's either the family already decide to do a palliative withdrawal, and they gathered during my shift. So my role, I go in and I confirm everything, explain the process to the family, put all the medication, tell them what they will expect, and then pronounce the patient. The other scenario,
Doctor,
like,
I apologize to interrupt you, but it's not responsive.
Okay, so you're entering an objection non-responsive. Doc, let's stop. Okay, we're gonna move to another question.
Dr. Hagris, I'm trying to cut it down and simplify things for a minute, so let me ask it in another way. If the patient's family comes to the nurse and says, we'd like to take our loved one off the ventilator and end care, that's one way the conversation can initiate for palliative withdrawal, correct?
it could, but I didn't see this in my practice.
Okay. Another way is after you are analyzing the care, you feel as a doctor that this is a topic you need to bring to the family's attention. That's another way, correct?
Correct.
And that can happen in a variety of ways. So for example, if the patient is actively dying on life support, that's something you want to bring to their attention immediately, right?
I'm okay with the concept, but not with the word immediately. So it's a patient comes to ICU and he is in very critical condition. So I would bring this immediately, but this is very rare events. Most of the palliative extubation that I did in my practice, this patient has been in the ICU for some time.
And at some point, with some patients, their condition gets worse, right?
Correct.
Okay, so if they're on vasopressors, for example, and they're maxed out on that medication of vasopressors, but their blood pressure is going down, progressively going down, you at some point have to have a conversation with the family to see if they want their loved one to die with all kinds of tubes stuck to their body, correct?
Objection.
Okay. I have to sustain, let's do this a little different.
Okay, sure. You at some point have to come to the family and have a conversation with them as to how they want, or the patient wanted, their final moments to be.
Yes, sir.
Now, when these conversations are had, you're not usually alone in the room with the patient's family, correct?
The nurse will be with me, and sometimes the chaplain.
Correct. So there is oftentimes Mount Carmel provides spiritual care assistance, I guess for lack of a better phrase, where chaplains get involved and other religious people who are there with the families during this time, during this hard time, correct?
Correct.
And in addition to that, the nurse who is assigned to that patient is also present during these conversations, right?
Correct.
Now, and that is when you have the conversation with them, correct?
Correct.
And it is your job to give them options, is it not?
Well, my job is to explain what is going on, what's the plan of care, and why the patient is not responding, And why I'm calling them to come to see the patient right now, because I expect this patient could expire, and I give them option, like, my recommendation is to do that and that, and this is up to them,
But it is ultimately the decision of the family members or the power of attorney, whoever's assigned as the proxy for the patient, to make that determination.
Correct.
Is that correct?
Correct.
Okay. That's not your decision, right?
No, my job is just to give them the facts and show them what I have and give them the options, but the decision up to them.
And have you had experiences where sometimes a nurse comes to you and tells you that the family wants to have these conversations?
So say it again?
Have you had an occasion, or do you have on occasions, a nurse come to you and tell you that the family is approaching them about this topic?
No, I don't recall this. I recall the nurse will come to me and will tell me that the family want to change the code status from full code to do not resuscitate A. But I don't recall a nurse comes to me and say the family wants to do withdrawal of care. I'm sorry.
Let me stop you there. I
this.
think you answered my question. I think you answered my
Okay,
question.
hold on. Doc, did you explain it?
I want to add, that the nurse will, the family will not come to tell me that we are ready to take the withdrawal of care or to take everything off, except there's ongoing discussion on days that the family is ready, they are aware that the patient is not doing well, and they are ready right now to withdraw care. But I didn't have in my experience, my practice, that the patient family will come from the first time, now, okay, I'm coming now, I didn't like what I see, let's take everything off. I didn't see this in my practice.
Okay, now, Doctor, you basically have described that during a palliative extubation, you follow your order set, correct? Do you recall testifying to that?
Correct.
Okay. Now, so at this point, if you're going to do palliative withdrawal, you basically tell the nurse your order set, and they go and get the medications, and they, at that time, perform the withdrawal, correct?
Well, before this, I will have a discussion with the family, and I will explain what's the process of palliative extubation, what the medication that I'm ordering, what they expect, and the nurse will be with me. Then I will go in and I will put my orders, and I will explain again the process to the nurse. And if she has any problem, she will call me. Then when he passes, she will call me to pronounce it.
I see. Okay. Yeah, I'm trying to walk through that process. If we could do that one step at a time. So after you explain what you want to the nurse, it is now the nurse who then goes and retrieves the medication, right?
Correct.
And administers it, right?
Correct.
And then you're gone, or do you stay in the room?
Yes.
Okay, you're gone.
My office is like 30 seconds from the. I'm in the middle of ICU. My office in the middle of ICU.
Okay, so you go to your office, and you are then called back in to give the time of death. Is that correct?
Correct.
Okay. Now, I want to go to the policy at Mount Carmel's palliative withdrawal policy that you looked at earlier in direct examination. And I know there were two shown to you. Let's bring up States Exhibit 16A. I'd like to bring up, which one is this? I need the actual record, so I can read it to record. Okay. Exhibit 12, page 811. see on the top right-hand corner that we're referencing patient Sandra Castle?
Yes, sir.
Okay, and the date of this note, if we can scroll down, I'd like to.
And before he does his question, Your Honor, I just want to note my objection for the record, knowing what you're ruling on for these.
Just doing the same exact.
Okay, well, I haven't heard the question yet. Go ahead.
Looking at the nurse's note for November 13, 2018, do you see that, sir?
November 13, yeah. What time? Is it 1944?
1941, the one that's entered at that moment.
Okay, 1941. Yes, sir.
Okay. Do you see the time that this patient was extubated at 1642?
1642, yes.
Okay. That is 4:42 p.m. in the afternoon?
Yes.
Okay. Before 4:42. If you can remember that time, I want to ask you some more questions about that. Now,
The time 4:42
yes, 4:42
p.m., right?
on
Okay.
November 13th.
Doc, just relax. I wrote it down. I got it for you.
All right. Now, if we can bring up Exhibit 12, page 896 to 99. Okay. Again, this is Sandra Castle. Would you agree?
Yes.
And we're looking at the medication administration record, right?
Yes.
And this is basically the medication that was given to this patient, correct?
Correct.
Okay. And we see at the top of this, in terms of medications, on the same day at 9:38 in the morning, she was given aspirin.
Yes.
And this was based on an order that you gave, I guess, on November 10th for her to get it at certain times during the day. Is that right?
Correct.
Okay. And then after that, you have another medication order that was also given. And this is, I'm not going to even try to pronounce that. Why don't you tell us?
It's a Lipitor, atorvastatin. It's a cholesterol medicine.
Okay. So as we scroll down later on that day, on the 13th, we know that she was extubated at 4:42 in the afternoon, correct?
Yes.
And she is given, prior to being extubated, at 4:34, there's an order for 100 micrograms of fentanyl. Do you see that?
Yes.
And this was ordered by Dr. Mand. Do you see that?
Yes.
And this is still the day shift, correct?
Correct.
Okay. So, just before she's extubated, she's given 100 micrograms of fentanyl. If we can go to the next record. Then at 5:50, she's given more medication of morphine. Do you see that?
Yes.
Okay. Now, if she's extubated, this here also gives a pain score, does it not? Do you see that?
I see that, yeah.
Okay. And that is a pain score of 9. Do you see that, sir?
Correct.
And I recall in direct examination, when you were asked about a pain score being severe, you addressed that 9 is severe pain, correct?
No, I didn't see that.
Okay. I remember you said that you're not familiar with the critical care pain observation tool. Is that correct?
Correct,
Okay.
correct.
When you, do you know that this tool only goes up to 8?
No, sir.
Are
I
you
don't
aware of
know.
that? No, okay. So let me take you through this then. You see that though, the pain score is at 9, correct?
Yes,
Now, that is about an hour after Ms. Castle's extubated. She's getting morphine. Well, prior she got fentanyl, now she's getting morphine, correct?
according to the record, yes.
Okay. And according to the record, the nurse noted her pain score at a 9, right?
Correct.
Now, if in that hour, a patient, now this is just general, not specifically to Ms. Castle, if a patient is suffering pain after being extubated, that's something that's oftentimes the family has to deal with, right?
Well, you're asking a hypothetical question, and in these cases, I need to know more about the patient. I'm here as a fact witness to talk about my practice. I didn't see this patient, I didn't.
Let me try and clarify the question, sir. When you're doing when you are performing palliative care, sir, and a patient is experiencing pain on their last moments, that's something that the family has to endure as well, correct? You're aware of that as a doctor, right? That's something you consider?
Sir, when I do a palliative extubation, the patient gets medication before I take the tube out. After taking the tube out, the patient will be assessed every 15 minutes. And he will get 6 milligrams of morphine and 2 milligrams of Versed. In my practice of 10 years in Mount Carmel, I'm sorry, I need to finish my answer. In 10 years, I did not see any concerning from any family regarding my palliative extubation.
Doctor, my question, let me get you back to the question, if I can. If you have to give more medication, that's after the patient has suffered pain, right?
No, sir, because the patient will be assessed every 15 minutes. If the nurse, she feels the patient did not get to the right score, okay, this means like, if I don't know the CPO2, but for example, it's from 0 to 8. A patient was 8 and she gave a medication and he went down from 8 to 4, but still didn't get to 0. So she will call me and I'll give more medication. But
okay, that's what I'm trying to get to. That's what I'm trying to get to.
Yeah.
So when the nurse notices that the patient's in pain, they call the doctor and the doctor orders more medication, right? To stop the suffering.
Right.
Okay, so
Correct.
here you see Dr. Mahoney now giving morphine, correct? At 1750, right?
Yeah, yes.
Okay, then 43 minutes later, this patient is given, do you see lorazepam in order for that?
Yes, I see it. Yeah.
Okay.
2 milligrams.
And then that's also ordered by Dr. Mahoney.
Correct.
The next thing, this is also given simultaneously with more morphine. Do you see that? At 1833.
Yes.
Do you see that?
Yeah. Yes, I see that, yeah.
And what do you see the pain score at now? At 1833.
8.
Okay. And what does the record tell you in terms of the reason for the medication?
Pain.
And what does it say
Severe
after
pain.
pain?
Severe pain.
Severe pain. Now, we now have 3 doses of opioids to address this pain, correct?
According to the record, yes.
Yes. And in addition to that, we're now looking at 7:03 p.m. If we can scroll down. And she's given more morphine, correct?
Yes?
Okay. And that is issued by Dr. Mahoney. Do you see that?
Yes, I see that, yeah.
Okay. And the reason for this medication is what, sir?
Severe pain.
Severe pain. Let's go to the next page, please. Do you see now we're at 7:18 p.m.? You see that, sir?
Yes, I see that, yeah.
And that's just 15 minutes after being given the morphine at 19:03, correct?
Yes, I'm sorry.
Do you want to scroll back up so we can answer that?
Yeah, I think the 1918 is not medication to be given. It's just an assessment. I think so 1903, this is the last one that I see right now. Okay.
Okay, so you see where I'm referring to. 15 minutes later.
But I don't think this is a medication was given.
Okay, that's not the medication. I'm sorry, I misspoke. 1933. Let's scroll down to that.
Correct. Yes.
On 1933, this is approximately 30 minutes later, this patient is given even more morphine, correct?
Correct.
And you see the doses are going up?
It's the same dose like last time.
Okay. And what is the pain score here?
9.
And who is the doctor?
That's Dr. Adam Mahoney.
Okay. And what is the reason for the medication?
Severe pain.
Now, sir, based on what you've seen there, how many times did the day shift of Dr. Mahoney administer opioids to Miss Castle? Okay.
I think it's 4 or 5 times.
4 or 5 times. And that is from 4:42 p.m. until I'm sorry, there's more. Let's scroll down. And let's go to (22:21). That's 10 p.m. Scroll down. Actually, stop right there. Before we get to the more morphine, she's also given lorazepam, correct? Or Atropine. Do you see that? And that's by Dr. Mahoney?
Yes.
Okay, and Dr. Mahoney, the reason for giving the Atropine was for what, sir?
The Atropine for pain, discomfort.
Okay, and then at 22:21, she is now given more morphine, correct?
Correct.
and the pain score is at 9 again.
Yes.
And the reason that Dr. Mahoney gave this medication was for what, sir?
Severe pain.
So, after palliatively extubating her at 4:42 p.m. until 10:21 p.m., that's about 5 hours, right?
22, yeah, it's from 4, yeah, about 5-6 hours, yeah.
She's given opioids 6 times to alleviate her pain and suffering. Is she not? According to these records?
Yes.
Are you familiar with what kind of order set or dosing regimen that Dr. Mahoney usually employs?
No, sir.
And in the event, sir, that in the review of a record, obviously, you would consider the amount of opioids that a patient is given at the hospital when determining, well, let me strike that. It's a jumbled up question. Tolerance is something you consider when deciding to give opioids to a patient, correct?
Correct.
And that's something that a doctor has to determine when they look at the records as to how much opioids a patient has received in the hospital during their current stay, correct?
I'm sorry, so you're saying that...
Let me rephrase it. I can see I confused you with the question. I'm wrapping up. Doctor, one of the things that doctors look at are the medical records to make a determination as to how much tolerance a patient has, correct?
Yes.
And that specifically, that includes opioids, correct?
Correct.
If I could have just a moment, Judge. I think that might be done. Dr. Hagris, the order sets that we've discussed here today, at Mount Carmel at the time of these events in question, they were not mandatory policies, correct?
Correct.
The decisions made were left up to the discretion of the doctor at bedside, correct?
Correct.
And that's something that the doctor can only determine, and that's something that the doctor looks at. Well, let me rephrase that. The best person to make that determination is a doctor at bedside, is it not?
Yeah, the physician, attending physician, he will look to the order sets and he will see what he likes and what he's comfortable using it.
Okay, thank you.
Redirect?
Thank you, Alan.
No, I can pull my gun.
Dr. Hagris, it's Paula Sawyers again.
Yes.
So we just went over Sandra Castle and the number of times the morphine was given to her after the palliative extubation. Why do you administer that medication so many milligrams per hour?
Well, after palliative extubation, the goal is to alleviate pain, discomfort, and anxiety and air hunger. So the patient will get morphine and Versed, and he will get it, or she will get it every 15 minutes per nurse assessment.
Why don't you just give them a big dose up front?
Objection.
Okay. Rephrase.
Sure. Why wouldn't you take all that you gave them over the course of those several hours and just administer one large dose at the very beginning?
Well, I was trained using certain doses and in University of Maryland East Campus, and all these years of my training, I never seen any one of my attending use more than these dosages, and we always had an excellent outcome. For this, when I came to practice, I inherited what I learned, and I found this in our order sets, in Mount Carmel order sets, and I started using that, and I never had any problem, never any bad outcome in palliative extubation. So I didn't see any indication to go beyond these doses in my practice.
Is there any risk to the patient by administering a large dose of morphine?
Objection, Judge.
Sustained.
You in your practice, would you see any risk in administering a larger dose of morphine immediately after extubation?
Objection, Judge. He's already testified that he has a specific way of practicing that's different.
I'll permit the question.
You can answer, Dr. Hagris.
You're asking me why I don't give more morphine?
Correct. Or why in your practice wouldn't you give more morphine right up front?
Objection, Judge. The same.
Okay, I understand. Overruled.
You can answer, Dr. Hagris.
Well, as I said, this is my practice, and this is what I trained, and I found these doses every 15 minutes are enough to control the patient's symptoms.
Okay.
So I didn't have any indication or need in my practice to go beyond these doses.
Okay. Can you go up to where it was the fentanyl order on page 896, please? Okay. Can I borrow them for a little bit? 896 would be the page at the very bottom. Okay, sorry. If you want to get out on
time that it did.
it would be 16:35, sorry. Bear with us, Dr. Hagris, we're getting to the page. No,
It'll come out. It's on here. It's just-
okay. Give it a sec. Okay. And Dr. Hagris, directing your attention to the fentanyl order at the bottom of the page here, how much was given for this palliative extubation?
That's 100 mics.
Okay, thank you. I can handle it from that here if I need anything. Now, Attorney Baez had mentioned your order sets. Are these your order sets or are they the hospital's order sets, sir?
No, the hospital order sets.
Let me get into the correct medical record here. And Dr. Hagris, you had said at one point that unless it's an emergency, you wait for the approval of the pharmacy. Did I hear that correctly, sir?
Correct.
Is,
We've already established that unless he hears from us, he doesn't know that there's an issue.
Well, that and, okay. We've already had this testimony.
Okay.
Let's move on.
in your experience, is a palliative withdrawal ever an emergency?
No, ma'am.
And just to go back to Ms. Walls, Rebecca Walls. And I'm going to direct your attention to the screen. Do you remember Mr. Baez showing you this midazolam order?
Yes.
What's the date and time that that was administered by you, sir, or by the nurse that you ordered?
November 16th, 2018 at 4:25 a.m.
Okay, and I'm going to go down a few pages. Nope, not that far. And Dr. Hagris, I'm going to direct your attention to this page. What were you doing with Ms. Walls at that time?
This is intubation assist form by the nurse, and this is where I did intubate the patient.
Does it indicate it's an emergency?
Objection, Judge, we're talking about intubation versus extubation.
Yeah.
Okay, hold on. Hold on, Doc.
Your Honor, he indicated that he does, if it's an emergency, he doesn't worry about the pharmacy. That was one point that Mr. Baez made on his cross-examination.
Question.
So, Dr. Hagris, does this indicate that this intubation was done on an emergency basis?
Yes.
If I can have a moment, Your Honor.
You may.
Your Honor, if I can have a moment.
Okay.
Hang on. I'll get into that. All right, thank you, sir. I have no further questions.
Doctor, thank you. Good luck with your father. Okay?
Thanks, sir. Thank you very much. Thank
Okay.
you. Have a good day.
We're going to take a recess, ladies and gentlemen. Okay, 15 minutes. We'll start back at 25 till. Okay, David, call him up.
All right.
Have a great break, guys. Okay, hold on, folks.
Paula, do you have anything else?
I've got something I gotta do, okay? I'll ask that question in a minute. When we were sidebar, I just wanna make sure you talked about the petition. Okay, you didn't use it,
I didn't use it.
but remember, 404 is still out there. Okay?
Okay, I'm not quite sure what. Am I being warned or?
No, I just don't want it to act like I was being misleading. When you go into the document, 404 may come into play. Okay? Okay, anything further?
Yes, there is
Miss-
something further, Judge.
Well, I was going to Miss Sawyer first, ladies first, there in Jesus'
Not on
States.
behalf of the state, Your Honor.
Okay, on behalf of you.
I'm sorry, I thought. Yes, Judge. During the last break for a moment, or while sorry, it's late in the afternoon. I'm a little off right now. During the last exchange during redirect, there was a moment in time where Ms. Grubbs stood up and was speaking to Paula in reference to something that I had done, and literally said, "He is wrong," and gave an explanation. Now, I could hear it way over here, and for the record, Ms. Grubbs is 3 to 4 feet away from the jury. I have an issue with the prosecutor making arguments and having these loud discussions about opposing counsel or defense's position that close to the jury. I think that's a major issue. I would ask that she repeat on the record what she specifically said so that it is indicated in the record, and then we can make a determination if we have any more motions after that.
Ms. Grubb, do you know what he's talking about?
I do.
Okay, what record would you like to make on the issue?
I was wrong.
Okay, well,
So, I mean-
you have the ability of being closer to the jury. You have to be extremely careful. Let's not have it happen again.
Thank you, Your Honor. I would request that you instruct the jury that I was
going
had an
to do-
I had some element of confusion and thought Mr. Bias was wrong in his conclusion about something, and that I was wrong.
My curative instruction is the passion of a trial. Sometimes attorneys blurt out, they know better than to do that, but sometimes it happens. You're to disregard anything you may have heard.
Thank you, and I apologize. My voice carries. I'm very sorry.
I appreciate Ms. Grubbs' sincerity, and I just think we need to know on the record what exactly she was referring to in saying, so I know if there's a
Do you
bigger
remember what
issue
you were
here.
saying he was wrong about?
I was confused as far as the time of the extubation of Ms. Castle.
Okay.
And I thought Mr. Bias was wrong about it, and I was wrong.
Okay. So I assume that's a kind of an apology?
It is, I'm very sorry.
I accept and appreciate the apology.
Okay.
I was directing it to co-counsel, not to him.
I know she was, yes.
The problem you've got is, it's like the pictures on the table right by the jury box.
I know.
Okay, you gotta be careful,
I accept that.
okay?
Thank you.
So could
Anything
we-
else?
Yes, so we could have an instruction upon the return of the jury.
I will instruct the jury upon their return about this situation.
Thank you, Judge.
Anything else?
Nothing from the defense.
Okay.
Between the two of us, I feel like we have it.
Oh, I'm not in the mix, huh? Okay.
Well, I don't think you want to get.
I don't wanna know?
Well, no, we were just talking about turning the microphone.
Yeah.
Sure. Before you go back, just about, just a quick question for witnesses.
Yeah.
After we finish this next witness, depending on what time it is, knowing that we have that March, or the way it goes Monday, Tuesday, or something, or do you want to start another witness?
You have one day off, and possibly
Yeah, well, yeah,
soon the second.
yeah, just was looking at it, would you want us to start another witness after?
Do you have somebody short? There is no short.
Yeah.
Okay, gotcha. We will bless the jury with an early exit today and enjoy the holiday. Leave it at 3 p.m.
Yes, as far as I know.
Yes. I was gonna say, because it looks like it's disconnected, so.
Yes, maybe the judge did that. Yeah, I can't see it.
Maybe I should go.
Yeah, no, go down. Yeah.
It's, hummingbird cake.
I don't refuse any kind of cake. If it's cake,
I asked her, I said, well, why didn't you make me a little bit right?
through the whole time
I mean,
anyway.
if it's some up that, some monitor is testimony, so.
They just don't be cramped over there?
So,
Shouldn't have brought it.
when people object, because
And
I can't get the objection, so it's.
see that little box down the bottom with like 9 dots
I'm sorry.
on your screen in front of you?
9 dots?
Well, it's like a little box down the bottom of the screen. You hit that, and then hit clear. I think it's the X. No, not the X. Maybe it's the one, no. Yeah, they got it. Okay, cool. There was that yellow up there. Someone had touched the screen, and it just kind of looks disgusting. So. Ladies and gentlemen, I hope you had a wonderful break. I need to do a couple of things. First, I passed one of you going down the hallway, and I looked like I was mad. Okay? It had nothing to do with this room. Okay? I love to cook and bake, and I was told I was wrong about a recipe. And I took it real personal. And the person who accused me of being wrong was very wrong. So, that was the first thing. The second thing is trials are very passionate things, and sometimes things blurt out from the tables. We had an incident during the last witness, okay? You're to disregard anything you hear there. It's like what you think I may be thinking, you're to disregard that too, okay? You guys are the sole determination of what the facts are, and you don't need anything intrinsic about it. Is that understood? So if someone blurted out something from the table, disregard it. Okay? Ms. Nash, are you ready?
I am, Your Honor.
Doctor, you're still under oath.
Your Honor, by agreement, I'm going to lead just a little bit so we can loop back.
Okay.
But,
You can lead anyway, can't you?
well, fair. See?
It's okay. At least you
I guess
didn't
maybe
correct
it's
me
more-
about hummingbird cake.
It's more asked than answered.
Okay.
Good afternoon.
Good afternoon.
Want to kind of circle back, and there's been this gap of time, so want to set the stage a little bit. Yesterday, I asked you about the time of day or the shift when the Pyxis machines were refilled by the pharmacy techs. Do you remember that question?
I don't remember that question specifically, no.
Let me ask you that now then. What shift or time of day generally were the Pyxis machines refilled?
There's two shifts, days and evenings, that they're refilled on.
And who is responsible for refilling the machines? Who was responsible?
It's the technician responsible that's assigned that task for that day.
And so machines are filled both in the day and night shift?
That's correct.
Was that true of the Pyxis machine on the ICU floor as well?
Yes.
Tell the jurors how the pharmacy tech would get the information that a machine needed to be refilled.
there's a printout report for controlled substances. For non-controlled substances, it would automatically reposit that information into our carousel, and then it would pull based upon a workload out of that. Pharmacist would check it, and then the technician would take it up to the floor and put it in the Pyxis machine.
So there's a separate printout for controlled substances?
Correct, that's not integrated into the system.
Because controlled substances are different from other types of medication, right?
Yes, they're stored differently.
And would you agree with me that there's more rules and regulations with respect to controlled substances?
Yes,
And why is that?
there's more oversight. They're controlled substances for a reason, because they have risk of being used inappropriately.
Which is why any possibility of diversion within a hospital is a pretty serious issue, correct?
Yes,
Stealing controlled substances, if employees were doing that, that could be a real issue for the hospital.
stealing of any medication is an important thing.
But particularly controlled substances, right?
Yes,
And fentanyl, Versed, and Dilaudid, just for examples, those are all controlled substances.
yes,
So there's a printout of the controlled substances that have been dispensed from the Pyxis machine on a daily basis?
no, that's a refill summary, so things that have gone below the par level that need to be refilled would be notified on that report, and then it would be pulled from that report.
What happens if I hit in an order, I being a doctor, I place an order and that medication isn't in the machine? That it's absent and hasn't been refilled yet?
So are you asking if something was normally stocked in the machine and it's stocked out, or are you asking if it's not stocked in the machine at all?
If it's stocked out and I order the med, what happens?
The pharmacist would verify the medication, the nurse would get a notification on the Pyxis when they try to vend it that it's below the amount needed.
And there would probably be some communication, right? Like maybe the pharmacist would call up or the nurse would call down?
Typically, the nurse would notify us, but we work ahead to try not to have that happen. That's a customer service opportunity.
And I ask these questions because I just want to go through the number of people that would know when, let's say, 1,000 micrograms is ordered and taken from a Pyxis. So we know there's the pharmacy tech that refills the machine. They would know.
No, they wouldn't know how much was taken out in one transaction at all. They just know how many are total in the Pyxis and if it's time to refill it, yes or no.
Sure, but if there's 3 machines on the ICU, right?
Yes,
And we know that you just said that machines are stocked day and night shift.
correct.
And I'm a pharmacy tech, and I bring my cart, and I come upstairs, and I go to one machine, and it's out of 1,000 micrograms of fentanyl, and I put those vials in to replace them, right?
Okay.
And then I wheel my cart to the second
She
machine.
asked, hold on, she asked if that was the procedure. Is that how it works?
It's different than she's describing it, but what the technician would do is look at the report. It would be checked by the pharmacist. They would bring up whatever number of it is, and it's based on vials. So there's also multiple patients in that area. So if you think that one Pyxis might service 10 to 12 patients, all of them could be on a ventilator. So it may be a wide variety of needs. So they could easily refill 10 vials.
I understand that, but you just told this juror that the machines are stocked day and night shift.
Yeah, 2 separate instances.
And as the manager of the pharmacy then, tell the jurors how much fentanyl was kept in any one Pyxis machine at any time on the ICU.
I can't recall that.
You don't know that?
I can't recall 2015 to 2018, is that the time frame we're talking about?
It is.
I can't specifically recall. I can give you an estimate if you'd like, but I can't give you a specific number.
I was really not asking for an estimate. But we know the techs refill the machines.
Yes,
We know the pharmacists see the orders for either prospective review, right?
yes,
And even for a retrospective review, even when they clear out the order, they still see it.
yes,
And then we also know that there's the nurse that administers the medicine.
Yes.
And then I guess the fourth layer would be the Pyxis reports themselves, right? As to, well, let me separate that. So those are at least the three layers that would know about any order that's placed with respect to fentanyl, correct?
The refill does not have any order information on it.
But I'm a tech and I go to a machine and I get the report that the machine needs 1,000 micrograms and I take my 10 vials of it. Isn't that what I do as a tech?
It could be, yes, it could be 10 vials and they would put it in. They don't know who dispensed that previously.
Understood, it was my question. They know how much a machine needs when it's in.
Yes.
And anyone in a hospital, if you know, based on your role then as a manager, could place a voice report.
Yes.
So it's not just like someone in management can do. A pharmacist could place a voice report.
Yes.
A tech.
Yes.
Obviously a manager. Even someone like a staff, like a janitorial staff member, if they saw something, they could place a voice report too.
Anybody employed by the organization.
Are you familiar, turning now to the issue of the overrides, and jurors, I'll be quick on overrides. You're familiar, are you not, that the Pyxis machine, as a matter of course, every day spit out an override report, correct? I'm sorry, not the Pyxis machine, but there were override reports generated every single day within the pharmacy.
At that time,
Yes.
I do not recall that.
If that was the case, if override reports were generated daily, would you then know if your pharmacists were reviewing them or not?
Probably, but I don't recall. So you're asking me something that I don't recall. And what would I do about something I don't recall?
Did you ever, as the manager, I know you told the jury that you kind of worked from 7 a.m. to 5 p.m. Did you ever just pop in on the night shift just to see how things were going?
I mean, I basically saw them most mornings when I came in.
But between 5 p.m. and 7 a.m., that's a 12-hour window? Would you agree with me on that?
Sure, it's a little bit more. Yeah, it's a little bit more than that.
14. Well, I'm a lawyer, not a math teacher. There's 14 hours, right, between when you leave and when you come?
Yes.
And a lot can happen in a hospital in 14 hours. Do you agree with me?
I do.
And even though you were just generally at the hospital, I think your testimony was from 7 to 5 during the week, did you consider yourself to be accessible during the hours when you weren't there?
Yes.
So let's just say I'm Talon Schroyer, and this issue came up at 3 a.m. in the morning. Is it your personal belief that if there was an emergency, Talon had an emergency, and he called you at 3 a.m., you would have been responsive?
If I woke up to the phone call, sure.
And because you know that a lot can happen in a hospital within 14 hours, did you, as a matter of practice, always keep your cell phone on?
I did, to my best ability.
And keep it close?
Yeah, it sits on my nightstand.
And so, I assume too, it's one of your, and you're still employed at Consultation.
That's correct.
I assume, given the large responsibility of a pharmacy manager, that being accessible to your employees is something that's really important.
It is.
You talked about yesterday about the communication in the pharmacy department. I remember the prosecution asking you what was the communication like in the pharmacy. Remember that?
They asked when we had touch points, yes.
Yeah, and I think it's been, 14 hours. So I probably don't remember the words correctly, but the communication you indicated was generally good in the pharmacy, right? People talk to one another.
Yes.
And you had these the pharmacists had morning huddles.
Yes, it's a shift-to-shift handoff.
And I remember the Columbus Police Department asking you about those huddles in your interview. Do you remember that?
I have vague recollection.
So as one shift and they sort of pass the torch to the next, there would be a morning huddle.
Yes.
Is that right?
Yes.
And these would happen as a matter of practice daily.
Yes.
And sometimes, and you, as you told the Columbus Police Department, sometimes you attended those meetings, those huddles, and sometimes you didn't.
Yes, if I had a conflict, I wasn't able to attend, I would, if I had something to pass off, I'd talk to the shift that was there. If not, I'd follow up afterwards.
We know from the testimony that there was 2 pharmacists during this time at Mount Carmel West. How many pharmacists were there during the day?
What day of the week?
It depends.
Yes.
Monday through Friday.
Monday through Friday, in 2015 and 2018, I believe there was, it varied between 6 and 7 typically.
And then on the weekends?
There's less, because there's less elective surgeries in that, so typically 4, and then they upstaff as the day goes on.
So 5 days a week, as an example, there's 2 pharmacists having a huddle with 6 or 7 other pharmacists when they shift change.
Approximately.
And then another 2 days a week, we've got 2 pharmacists talking to maybe a handful of pharmacists.
Yes.
And some days you attended those huddles.
Yes.
Yet at no time in 2000, let me back up. And certainly if you had been in a huddle with your pharmacist and you had heard anyone raise any concern in a huddle, if there had been orders that had come through that were hastening the death, you would have done something about that.
Yes.
You would have issued a voice report.
I would expect that person that's reporting it to issue the voice report, but if not, I would, yes.
You would have, like you did with Town, you would have told Town to issue a voice report. If that didn't happen, you went to Katie in this one instance, right?
In the first instance, yes.
But in all those huddles, so we look to 2015, you never, no voice report from you that in a morning huddle, it was reported there's medication that might be hastening to death.
Did not place any other voice report. You know, the first incident I was aware of was in October.
October of?
2018.
And the huddles were happening in 16?
I can't tell you the exact date that they started. It was sometime before that, though.
Let me get mine. Certainly, I want to just go back to your interview with Columbus Police Department. You're talking specifically about the year 2017, and that's when you indicated that there were these morning huddles with the pharmacists, correct?
I don't remember the specific date I stated.
Did you create the huddle as a policy within pharmacy to do, or is that something pharmacists just naturally came to?
No, that came from our leadership team above myself.
So it was actually a directive that they were to huddle when they were transferring their shifts?
Yes.
And as the manager, if you know, what would be the value of having a huddle when pharmacists were transferring from shift to shift?
Information sharing, we've had a lot of shortages and other things during those times, so things were changing with those quite frequently. So it was an opportunity to get everybody on the same playing field.
So that if I saw or heard or had an issue in my night shift and it needed to be continuously watched, I could pass that information along to the station.
Yes.
There wouldn't be a gap in service, if you will.
Yes.
And so then going back, I should have started with 2014. No voice report from you with respect to any concern or indication that meds or fentanyl was being used in hasten any death, right?
As I said before, 2018 in October was the first instance.
So we can assume the same is true for 15 and 16 and 17.
Correct.
controlled substances, lots of heightened rules and regulations with respect to those types of medications.
I don't know what you quantify lots with, but yes, there's more scrutiny around that.
Let's talk about regulations on something like fentanyl versus regulations on something like acetaminophen. Different, right?
Yes.
And the reason, as your job as a manager, I remember you saying that safety is one of the critical functions of your job, right?
Yes.
And you're a fixer. Remember you talking about that too, right? Things were broken and you fixed it.
Well, I facilitated the operation working smoothly. So if equipment was broken, yes, I would facilitate getting it fixed.
And would you also agree that the operation overall under your supervision was the pharmacy as a whole?
You can infer that.
And if controlled substances aren't being properly regulated, you would
Object. He's never testified that.
Okay, overruled.
rules and regulations with respect to controlled substances, right? If they aren't being followed, a hospital could suffer certain consequences as a result of not following the governmental rules and regulations with respect to controlled substances, correct?
Correct.
You could lose your funding, your Medicaid funding.
Yes.
You could lose your Medicare funding.
Yes.
Anything else?
Yes. There could potentially be criminal charges.
I don't know about that.
No. Let's move on.
Okay. So then I'll circle back to my line of questioning about communication. We know about how the communication was within the pharmacy. And I think when I asked you how many times in the course of your career as a pharmacist that reviewed orders did you call upstairs, and I think your testimony was maybe that.
Probably.
So we know that your communication up is also good.
Yeah, well, you said communication with physicians, if I remember correctly, and I said I was on the floor, so it's a little easier to have a conversation with them, but yes.
Did you ever work not on the floor, just
Sure.
at pharmacy level on one?
Definitely.
And any issues, you could just call and say, hey, what's this order for? And clarification?
I could try to, yes.
You would agree with me, though, that in all these 2014, 2015, 2017, and finally even in 18, you as the pharmacy manager never picked up the phone and called Dr. Husel.
Why would I?
Well, why would you?
Okay, hold on. You don't get to ask questions.
Oh, I'm sorry, I didn't know.
She asks questions, you answer them.
Okay.
Okay, so don't do that. You want to rephrase the question or ask the question again?
No, so your answer is no.
Correct. I did not
So
review orders for him.
when you got this call, not call, when Talon told you while you were getting coffee that there was a call he got from a nurse, right? And you had that information and you took it up to Katie. You never reached out at any point to get any clarification from Dr. Husel regarding that.
Correct.
And at no point in time, in fact, ever, up to today, have you ever, in your capacity as manager of the pharmacy or a pharmacist,
Object. Relevancy.
Wow, it was asked yesterday.
No, I never asked if you called Dr. Husel yesterday.
I think you did, but, okay. You got that question in
You
already.
never called.
That's asked and answered. We already got there, we're past that. Your next question, she's objecting to.
Okay. So, give me 1 second. But I'm just going to end with voice reports. Tell us where you go. Because I think there's one voice report
terminal in the health system.
And that's why I asked that question. It could literally be any terminal within that whole hospital, am I correct?
Yes?
Do you have any estimate? Well, let me ask this. During this relevant time frame, were you generally familiar with the ICU?
Not terribly. I mean, what do you mean by generally? Sorry, I can't ask a question.
No, as the manager of the pharmacy of Mount Carmel West, did you ever walk up to the ICU?
Definitely.
And so visually, if you can, just to guesstimate, and I am asking for, because I'm not expecting you to know exact number, but would you agree that there's a significant number of terminals in the ICU floor alone?
Object. You already have established that there are 3.
No, that's a Pyxis machine.
Fax machine.
This is a terminal.
Oh,
Where if I had a problem on the ICU floor, I could go to any terminal, correct?
Correct.
If I saw something that was wrong, I'm just curious how many terminals would be available to me if I'm on the ICU floor?
More than 20.
Nothing further.
Redirect.
thank you, Your Honor. Couple of preliminary things. And then these, Diane.
I don't think, I just really speaking of time because we would be moving. I don't think we need to talk about that.
Okay, all right.
These are mine. Okay, don't have a problem.
Good afternoon. How are
Hello.
you today? Just a couple things. First of all, are pharmacists trained to diagnose patients?
No.
Are pharmacists trained to determine cause of death?
No.
Yesterday, there was some discussion
Your
about...
Honor, sorry, I think we agreed to talk about the settlement, this one document.
No,
Okay, no,
I
she's
still
going
have
to something different.
redirect.
Hold on. My courtroom.
Oh, my bad.
Okay, hold on, no. You're right on what you said, but she still gets a redirect. And then we can determine the rest of that issue.
The flow is totally off.
I know, well, we've interrupted it, what, a chunk of time? I'm not gonna do math in front of y'all, okay? But,
I've been lost this afternoon, so...
okay,
Okay, so, yesterday there was some discussion about cocaine and marijuana. What class of drugs are they?
Those are Schedule 1 drugs.
Okay, are those opioids?
No.
You previously testified that, this afternoon, that the Pyxis machines were refilled days and evenings, and then somehow evenings morphed into nights. Can you tell us is it days and nights or days and evenings?
It's days and evenings.
Days and evenings. And describe for us what the evening hours are, please.
That'd be 1500 to 2300.
Okay.
So 3 p.m. to 11 p.m.
Okay, 3 to 11. Okay, I'm going to present to you do you want to look at it again, Diane? You've looked at it.
As long as,
Yeah. I'm going to present to you what's been marked as State's Exhibit 25.
is this what our discussion was about earlier?
Yes, Your Honor.
Okay. Since I don't see it.
Dr. Miles, what is this document?
So a settlement with the Ohio Board of Pharmacy.
Okay. And do you know why this document came to pass?
Yes,
Can you tell the jury why?
from the events that happened from 2015 to 2018 in Mount
Okay.
Carmel West.
And it's a case number, there's a case number on here, correct?
If you could refresh me, but I'm
Okay.
confident there probably is one.
All right. May I
Any objection?
publish?
Yes,
And just before I publish, did you sign this document?
I did.
Okay. Okay, this purports to be a settlement agreement between the pharmacy board and the hospital, correct?
Correct.
Okay. And I'm going to flip to the back page. And there appears to be signatures there. Who all signed this document?
Dr. Nicholas Kriatsolis, our Chief Clinical Officer, myself, an attorney, and then the Board of Pharmacy folks.
Okay. Did this document require certain things to be done by the hospital?
Yes.
Okay. And can you talk to us about what those were?
Do you want specifics, or would you like me to read the document?
Yeah. I can.
No. He can talk about what he knows.
Yes. Yeah.
So it's actually all in the document. I don't want to misspeak.
Do you want to
The
look at
gist
it?
of it is that the hospital will fulfill certain obligations that were defined by the Board of Pharmacy, and also pay for a consultant to have intermediary checks for the next several years.
Okay. And was there a fine?
Yes.
Okay, and costs? Okay. So there are terms listed. And those are contained on 5 pages or 6 pages. Would you like to refresh your recollection, or can you tell us what the principal terms were?
Ms. Menashe, since she's going through a list, would it be okay if she went using direct questions? Leading?
Okay. Thank you. Did the hospital pay investigative costs?
Yes.
And there's some licensure requirements in order to maintain the license.
Yes, there's some
Were there certain
requirements.
things that had to be done?
Yes.
Okay. Were there requirements as far as possible patient harm?
Yes.
Okay. And are those listed here under, on page 3, under 5A2?
Yes.
And that involves certain things that have to be done if patient harm is in question, correct?
That's the review for that, but yes.
Yeah, okay. There also has to be meetings, correct?
Correct.
And safety huddles.
Yes.
And then there's also, finally, under number 5A8, a requirement that the hospital has to conduct a review of mortalities, correct?
Yes.
In 15 different categories.
Correct.
And the last category is any patient whose cause of death is determined to be respiratory failure or respiratory depression or adverse sequels related to respiratory failure or respiratory depression who concomitantly was administered a benzodiazepine or opiate. There must be a review. Is that correct?
That's correct.
There are also provisions in here that relate to what would happen if there were a failure to abide by the terms. Is that correct?
That's correct.
Okay. And then there's a lot of other verbiage in here that I'm sure Ms. Menashe may ask you about, but I'm not going to, so.
Ms. Menashe, on the exhibit?
Yes, I just need, I know my boundaries. But I just said.
This is what we call punchy Friday afternoon. Okay? Don't take any inference about that. We're all working fine together. But Friday afternoon can be a little bit of like too much time with your kids, you know? Not that they're my kids or anything.
Thank you. Oh. Showing you what's been marked as State's Exhibit 25. Page 1, would you agree that's essentially the case caption there? Names the parties?
Yes.
And under Mount Carmel Health Systems, your name appears as the responsible person,
I
correct?
was the responsible person of Grove City.
And which explains why your signature is on the back of the settlement, correct?
Correct.
And you're the only pharmacist, you're the only license number of the individuals on the settlement signature page is just you, right? You're the only one.
That's the hospital's license number.
Oh, the hospital, and so you're the, and so to this point, it says Grove City there.
Correct.
So I want to be clear, and tell me if I'm not correct, but this settlement wasn't things that Mount Carmel West needed to fix. This settlement is things that Mount Carmel Grove City needs to do to have a license to operate.
It had a license to operate.
To continue to have a license to operate.
It was associated with that, yes.
And this amount, just the $400,000 here, that obviously, despite you being named, you didn't pay that, correct?
Personally?
Yes,
No.
personally.
Personally,
Nor any costs, you didn't pay that.
personally, no.
And then I just want to go here to this, page 3 of the document. Talking about reported events and what must happen with confirmation from senior leadership, that senior leadership must do a review of all reported level 5 and higher events. Do you see that?
I do.
And which just draws me back to State's Exhibit 22A, reported as a level 4 event. Correct?
Yes.
Determined as an actual severity of a level 4. Correct?
Correct.
And I understand my boundaries, but just so we're clear, the levels escalate, so 5 is higher than a 4.
That's correct.
And then if I could, State's Exhibit 22B, With respect to Rebecca Walls, you entered that as a 0, and actual security level was determined to be a full, correct?
Yes.
And then lastly, with respect to Melissa Penix, that voice report was entered as a
Declare the exhibit number, please.
State's Exhibit 22C. That voice report was entered as an exhibit, or I'm sorry, as a 4 level of severity,
Yes.
and actual level of severity was determined to be full.
Yes.
Nothing further.
You may step down. I was approached by one of your associates, Mr. Zion, saying depending upon the hour, do you have another witness?
We do have another witness, Your Honor. In normal circumstances, I'd say let's put her on and we can rock and roll.
Well, this is my worry, okay? Monday, we've got the one doctor coming in that can be here for a day.
That's right.
So we have to take him,
That's right.
okay? He may carry over into the next day, and then I thought you had another commitment on a doctor after that.
We have commitments on we're doing flow charts at this point, Judge. We have so many commitments on doctors.
The witness that's going to be called, is it a fact witness or an opinion witness?
It's a fact witness, Your Honor. It's Katie Barja is the next witness in our order, the author of some of those reports.
She's going to be longer than an hour and 20 minutes.
We can, yes, but then on Monday morning, we were asking that we,
Okay.
if we don't get done with it, we're asking that we go to the other doctor.
I'm going to turn to you guys. I'm not going to listen to them anymore, okay? We can put on a witness and go till 5, okay? With the idea we're hoping to get this done in time, like we were told, okay? Or I can send you home for the weekend. You guys want a quick break to talk about it? Okay, let's take 10 minutes. David? And this is one of the reasons why I was not going to schedule things on Friday. I'm just stopping. Okay, I'm not letting, guys, let me have your attention. Yeah. Oh, I'm sorry. That's okay, my fault. I should wear my glasses when I do this. Oh. Here's my thought, okay? I imagine everyone will go home early, but I'm worried about the amount of gap that we're going to be forced to go between her starting her testimony until we can finish her up. And I have too many variables. Well, we still, if the jury wants to go home, I'm going to send them home, to be honest with you.
Yeah.
Okay? Would you just soon bark along and we go where we go with it?
It's Ms. Next witness, Judge. I'll defer to her when she'd like.
I'll defer to the court, Your Honor. I have no preference. Just knowing the lockout would be there was my only concern.
Okay, well, let's see what they vote. If they want to continue on, you put her on. If they don't want to continue on, I'm going to send them home.
Sounds good.
Okay? It's been a long day, and this room is getting warm. At least me in the robe. These robes aren't air conditioned, folks. You remember the days of the old courthouse? You were off. Not the one across the street, the one that was on across the street they destroyed back in the 70s. That was before you. The building had no air conditioning, so literally during the summers, it would shut down. Now, I never practiced there, but I'd been there as a kid on like tours and stuff.
My husband worked in there.
Yeah?
Yeah, he was Craig Wright's bailiff. And he was in there.
And you still married him? Wow.
For a little bit.
Yeah, okay. So you reformed him. Yeah, Judge Wright was an interesting character. I was just a pup when he was on ours, before he went to the Supreme Court. Yeah. They want to stay? Okay. You guys ready? We need our court reporter back.
I was just getting this phone.
We're going to go to 5. Huh? Okay, well, let's rock. Okay, and your last name, hope I can keep it right during the whole thing?
M-I-C-K.
I think I can get close on that one with my first name. No, you just have that Swanson look about you. Okay. Miss Mick, call your next witness.
The state would call Katie Barja.
You gonna swear? Yes. I know you've been dying too, and I denied you what you really do. Gentlemen, there's going to swear you in.
Do you swear or affirm to tell the whole truth and nothing but the truth, so help you God? I do.
Dave, you can lower your mask there so they can hear you, because when you go to your lower octave, it's a little tough.
Okay.
We'll need to scoot in a little bit towards the microphone. If you would be so kind as to state your name for the record and spell your name.
Yes, it's Catherine Barja, Kathryn, B as in boy, A-R-G-A.
Miss Mick?
Good afternoon, Ms. Barja. Can you please tell the jury your education following high school?
Sure, I went to nursing school and graduated with my RN as a registered nurse.
And what year was that?
2002.
And did you have any education following that?
I did. I got my master's in nursing in 2010.
And following your graduation, when you received your RN, how did you become employed?
I worked at Mount Carmel East in a cardiac step-down unit as a staff nurse.
Okay, are you guys hearing her? No. Okay. I imagine you can knock that mic down. Let it rip, so we can hear you. You're in this fish dome there, and it kind of echoes up.
I understand. Where should I start? I'm sorry.
You can repeat your last answer when you...
Okay.
Your first job.
When I graduated nursing school, I went to work at Mount Carmel East as a staff nurse on a cardiac step-down unit.
Okay, can you guys hear her better? You want more? I've seen a few of you leaning into her. Okay. We'll see. Okay. Do your best for us there. I know it's late in the day.
And how long did you work in that role?
About 7 years.
And after that job, what was your next job?
I went to work briefly for about a little less than a year for a cardiology practice that was associated with Mount Carmel.
And when did you first become employed at Mount Carmel West?
At Mount Carmel, I was actually a system employee. I went to work at West in October of 2017.
I guess so after your cardiology job, when what was your next job?
I worked in patient safety risk management at Mount Carmel East.
And what year did you begin that job?
2010.
Could you tell us, is that your current role today?
It is.
What are the general duties of that job?
Typically on a daily basis, we're reviewing the incident reports. So anytime there's something that occurs in the care of a patient that they would consider abnormal, we would expect that staff would document those in an incident report. So we review those and review issues of patient harm or the risk thereof.
When you say incident report, are you referring to what we've heard referred to as a voice report?
Yes.
So who is it that can put in a voice report? Is that employees or is that patients as well, or patients' families?
No, it's just employees.
And after a employee enters a voice report, how does that voice report end up with you?
It's an electronic system, so the life of it is once it's entered, it goes directly to those who have been assigned to receive the report, typically the manager and director of that respective area, as well as patient safety risk to review.
So when you receive a voice report, can you walk us through what your response would be?
Typically, like I said, the manager and director would be responsible for the investigation of whatever the event is reported. If we're concerned that something led to a patient harm, the patient safety risk officer would be involved in helping with that investigation as well.
Ms. Smith, you can turn that other one around where you got a mic, if that's more convenient for you.
Sure.
Just so you don't have a mic over there, so that's fine.
Yeah, I didn't realize that. Thank you.
Is that better, guys?
I haven't heard it yet. Thank you. Is this better? Yes. Okay. All right. So if you receive a voice report and determine that there was patient harm, what would your next steps be just generally?
Well, part of that investigation obviously would be talking to staff involved in the care of the patient at the time the incident occurred, speaking with subject matter experts to kind of understand how something happened, why it happened, and how we could prevent it from occurring again.
When you say subject matter experts, are you referring to other employees within the system, within the healthcare system?
Correct.
And at any point, does your job and duty also include a root cause analysis?
Yes.
And could you explain what that is?
As I mentioned, part of the investigation into some events, specifically harm-related events, or you could do it for any type of incident that will require more investigation, you would, again, have a team of subject matter experts come together to talk about what happened, how and why it happened, and what could be done to prevent it from occurring again.
Ms. Berger, I'm going to show you what is identified as State Exhibit 22D. May I approach your honor?
May.
Ms. Berger, are you familiar with this document?
Yes.
Could you tell the jury what it is?
It is the Mount Carmel policy for incident reporting.
And did you happen to notice the date on it?
I didn't catch that.
Do you see the date on
I
that?
can see the date, May 15th of 2018.
So is this the policy that was in a...
When you turn, you concentrate, your voice goes down. It's human nature.
Sure.
These guys have heard me say that before. Just remember that, okay?
Okay.
So you gotta belt it out still.
Does that indicate that this was the policy in effect following May 15th, 2018?
Yes, that's correct.
All right. When an employee enters a voice report, do they have the duty to enter an initial score of safety?
According to the policy at the time, there was a reported severity level. that according to the policy says what's known at the time that they're reporting the event, yes.
So when we look at a voice report and see reported severity level, that would be something the filer of the report entered.
Correct.
Right. And when we see the actual severity level on a voice report, who entered that score?
The patient safety risk officer.
And can you go over and explain the scoring system for the severity to the jury, please?
So a score of a 0, as you can see, is not applicable or unknown, and it ranges from 0 to 9, where the event would have contributed to the patient's death.
Those are the rest of the scores from 5 to 9?
Correct.
Right. Turning your attention to this matter, at some point did an issue with Dr. Husel come to your attention?
Yes, it did.
And can you tell the jury how that happened?
I can't recall specifically, but I believe it was a phone call from Randy Miles, the manager of the pharmacy at the time, that there was concern about medications that were administered.
And what happened after Randy called you?
To my recollection, I believe he and I approached Dr. Swanner, who was the Vice President of Medical Affairs at the time, to discuss what the concern was.
At some point after Randy called you, actually, can I show the witness identified as State's Exhibit 22A?
Approach.
Ms. Barja, are you familiar with this document?
Yes.
Could you please tell the jury what it is?
It's an incident report that was entered based on the dosages of medications that were administered to a patient as part of a palliative ventilator withdrawal.
And when we look right here at the entered by, does that indicate that you were the employee that physically entered this report into the computer system?
Yes.
And was this in response to, was this after the phone call that you received from Randy Miles?
Yes.
And was this before or after you and Randy took this to Dr. Swanner?
I don't remember exactly, but I believe it was after we had the conversation with him, with Dr. Swanner.
So this report, is this the patient that you entered it for?
Yes.
And when we look at the reported severity level, were you the individual that entered that score?
Yes.
And can you explain why you rated this as a 4?
Based on what we knew at the time, there's a brief timeline of the events, as you can see that in the report. We weren't exactly certain if the dosages of medication are what led to the ultimate outcome to the patient.
So after you took this to Dr. Swanner, what happened next?
He suggested sending it over for peer review, because obviously the question was related to physician practice, which is typically how those events are managed.
And to your knowledge, did that peer review ever happen?
I believe it happened, yes.
Did it happen that month?
I don't believe so.
Okay. So after you filed this voice report and took it to Dr. Swanner, did anything else occur in your investigation of this specific incident?
Of this specific incident, not that I recall.
And can you explain, you initially entered a 4 for the reported severity. Why did you enter a 4 for the actual severity level?
Again, it's a required field. Once you're reviewing the incident report that you have to document, it can be fluid, it can be changed based on the results of the investigation. But just the same as the reported severity, I didn't know anything different at the time.
I guess when we looked at State's Exhibit 22D, score 0 indicates NA or unknown. Is there a reason that you did not use the 0 for unknown at that point?
Well, if you look at the scoring and how it ranges, 3 is that the event reached the patient and caused no harm. We know that the medications were administered to the patient. We just didn't know if it had led to any harm.
So my understanding is correct that because it got to the patient, you couldn't use the 0, but you couldn't determine the cause and effect, so that's why you chose a 4.
Is leading,
I'll
dragging.
withdraw that. Is there a reason that you didn't, I guess, go for a higher score, like a 9 specifically?
Again, 9 would be that the event contributed to the patient's death, and we weren't certain at that time, based on the investigation up to that point, that that was the case.
Thank you. At some point following this, I would like to direct your attention to November. Did any other incidents come to your attention regarding Dr. Husel?
Yes, there was another event in November.
May I approach, Your Honor?
May.
I'm going to show you what is marked as the State's Exhibit 22E. Ms. Barja, do you recognize this document?
Yes.
Can you please tell the jury what it is?
It's another incident report regarding another patient where there were concerns reported about dosages of medications.
And on what date did this report come to your attention?
I believe it was November the 19th.
Yeah. Sorry, there you go. And looking at this report, can you tell who entered it into the voice system?
Yes, Randy Miles.
After Randy entered this voice report, did it come to you for review?
Yes.
Can you tell us about what you did in response to this voice report specifically?
He had notified me of this again. I can't remember if it was via email or a phone call prior to it being entered into the voice incident reporting system. I believe we again approached Dr. Swanner for an additional concern about dosages of medication and the overall process of how the medications were removed from Pyxis. I believe on this case it was prior to pharmacy authorization. Again, because it was physician practice, we sent it over for peer review. Does that answer your question?
Yes, thank you. May I approach, Your Honor?
May.
I'm going to show you what is marked as State's Exhibit 20F. Ms. Barja, you indicated that you believed you had received an email from Randy Miles. Is that this email that you were talking about?
Yes.
Right. And then, is this an email that you then sent?
Yes, it looks like after we had met with Dr. Swanner, I had sent him the report via our voice system and also sent him the report that had occurred back in October. And I also let him know that I touched base with Rose Mall, who was one of our people in quality that helped facilitate the peer review into these incidents. And that's when we learned that the November meeting had been combined with December.
And you mentioned Rose Mall is in which department?
Quality.
And what does quality do?
I can't speak to specifics, but at least related to this, she was in charge of reviewing the incident as well and making sure that it gets to peer review.
And you also addressed Dina in this email. Who is Dina?
Correct. Dina Bush was the chief nursing officer at the time.
And why were you bringing this to Dina Bush's attention?
Because Randy had mentioned the concern from the pharmacist about the nurses removing the medications prior to pharmacy approval of the medication and review.
And then after you sent these emails, what occurred next in the timeline with Dr. Husel?
I believe that at least internally we had scheduled a meeting to review the nursing and the pharmacy concerns. As far as Dr. Husel was concerned, I don't know what happened after the specific email.
Did any additional incidents come to your attention?
Yes, there was another incident that was reported on Wednesday, which I believe was the 21st.
May I approach, Your Honor?
You may.
I'm going to show you what is marked as State's Exhibit 22C. Can you please explain what this document is that I just showed you?
It's another incident report regarding a patient who the staff was concerned about dosages of medications administered.
And is this the voice report that was entered following that third incident you just mentioned?
Yes.
All right. And it looks like, who entered this voice report?
I did.
All right. Are you the individual that entered both the reported severity and the actual severity levels?
That's correct.
Can you please explain why you entered a 4 for those scores?
Again, based on what we knew at the time, we knew that the dosages of medications did reach the patient. We just could not determine the actual harm.
And now after receiving these 2 reports, what was the next step that you took in your role as a risk safety officer?
So this was escalated again to Dr. Swanner's attention in addition to Dina, the chief nursing officer, as well as Sean, who was the president at the time. There was a meeting that was held shortly thereafter. We became aware of the third concern, and then we determined that we wanted to take a deeper look and to see if there were additional cases that we were not aware of.
May I approach?
May.
I'm going to show you what is marked as State's Exhibit 20E. Is this an email that you received regarding that incident? That you
Yes,
just
it is.
Is this an email that you then sent after?
That's correct.
Can you please, it looks like you sent that to Cheryl and Holly.
Yes.
Who is Cheryl?
Cheryl Wolf at the time was the director of patient safety risk management.
And who is Holly?
Holly is the regional vice president of clinical quality.
So is Cheryl, I guess at this point, your superior?
Correct.
And why did you send this email to Cheryl and Holly?
So they were aware of the incidents that were reported and for her to escalate up her chain of command as well, since we were meeting to discuss things further as far as next steps.
And then, is this that same email that you had received from Randy?
Yes.
And then, is that an email that you sent?
Yes.
And can you please identify the 3 individuals that you sent this email to?
Yes, Dr. Larry Swanner was the vice president of medical affairs at the time. Sean McKibben was the president of Mount Carmel West, and Dina Bush was the chief nursing officer.
And why did you send this to those 3 individuals?
That's who we were meeting with to discuss next steps regarding the events that we had reviewed.
Looking at the importance, is that something that you marked in sending that email?
Yes.
And when you asked them if this could be managed sooner rather than later, did that end up happening?
Yes, as I mentioned, we met later that morning to discuss next steps.
To the best of your knowledge, who all met that morning?
The 3 individuals listed on this email, I believe there were some pharmacy representatives. I can't remember specifically who was in attendance. I know the ICU manager and I believe director were also in attendance. The director of quality, I believe Cheryl Wolf, the director of patient safety risk, and I can't recall if Holly was there or not.
And what happened as a result of this meeting?
We discussed again what next steps were to see if there were further concerns that quality could pull based on certain data points to see if there were more patients involved that we didn't know about.
So we mentioned root cause analysis earlier. Is that something that was initiated in this matter as well?
I don't believe it this time. Again, we wanted to understand the scope of the concern.
So following that meeting that morning then, what happened next in the timeline?
I believe we met again as a team the following week and had some of those follow-up items that we brought back to the meeting. There were several more patients that were identified as receiving similar doses of medication. That's what I recall specifically about that meeting.
And during that week, what were you doing in your role as part of this investigation?
There was a comment that there was an incident report that was also reported in addition to the 3 that we had already reviewed. So I went back and looked at 6 months worth of incident reports from the ICU to see if there were any similar incidents reported, and we didn't see anything additional.
So following the last meeting that you just mentioned, what happened next?
I was asked to begin interviewing the nurses that were involved on the spreadsheet that quality had devised. So I started speaking with those nurses that were involved in the administration of those medications.
And what was your purpose in speaking to the nurses?
As I mentioned earlier, anytime we have any type of patient event where there could potentially be harm, we would speak with those caregivers that were involved in the care of the patient at the time.
Did you speak with all of the nurses involved?
I don't recall if it was all of them. I believe I might have.
After you spoke with the nurses, what did you then do?
I believe there was a root cause analysis at some point after this. I believe that was the next step, at least with my involvement.
So when you were doing a root cause analysis in this matter, what was the purpose of that?
To identify what had happened, how and why it happened, and how we could prevent that from occurring to another patient.
And were you the only individual doing this root cause analysis?
No.
Who else was involved?
I don't have the list of people committed to memory, but the 3 people mentioned here as far as Dr. Swanner, Sean McKibben, Dina Bush. I think there was somebody from Trinity, Dr. Lundstrom was there as well, other subject matter experts that could speak to the nursing process, the pharmacy process. There was a physician who was a palliative care physician that was also on the team from what I recall.
What you mentioned there, that someone from Trinity was involved, are you aware of when this was brought to Trinity's attention?
I know it was at some point. I don't know when.
But it wasn't you that notified Trinity?
No.
Okay. And did you mention that pharmacists were also interviewed?
Not by myself.
Okay, but someone did interview pharmacists
Yes.
as part of this. And after these interviews were conducted, what else was done to investigate the situation?
After the interviews were conducted, like I said, there was the rest of my team assisted in interviewing pharmacists that were involved. We had the root cause analysis, developed an action plan to prevent reoccurrence to other patients. Beyond that, I don't know how much I can answer.
Can you explain what the action plan is that you just mentioned, generally?
Generally, it was anytime we find system processes that we have an opportunity to improve, we would develop an action plan around what those root causes and proximate causes were, which was part of that action plan.
Did you find any problems with the nursing system as part of this root cause analysis?
I believe we did.
And did you then develop an action plan for those problems?
The team developed an action plan, yes.
Were there any problems identified with the pharmacy system in this
Yes.
investigation? And then did you create an action plan for that as well?
The RCA team did, yes. The RCA team, root cause analysis team.
Yeah, anagrams are a problem for us some days, okay?
And then after the root cause analysis was completed, actually, when you were conducting the root cause analysis in this investigation, was Columbus Police Department involved in that?
Involved in what, I'm sorry?
Your root cause analysis in
No.
the investigation?
No.
Was the prosecutor's office involved in that?
In the root cause analysis? No.
Are you aware of when the police and prosecutor's office were contacted in this matter?
I don't know the specific date.
Did, at any point, did the police meet with you to investigate these system failures that you were describing with the action plans? Or was that something that the hospital did internally?
I'm not sure I understand the question. I did not personally meet with Columbus Police.
Sorry, that was poorly worded. I guess I'm asking, so this investigation that you did was only hospital personnel involved?
Correct.
And when the hospital was investigating this, did you focus on whether crimes had occurred? Was that something that you were determining in your investigation?
No.
Right. After this root cause analysis was completed, were there any further meetings that you were involved in?
Yes.
Can you tell us about that?
I don't recall specifics. I know there was a lot of education that was rolled out in the system as far as trying to address those opportunities with pharmacists, with nurses. I can't recall specific meetings.
May I have a minute, Your Honor?
You may.
Following up on the 3 voice reports, you were the one that entered the 4 for all 3 of those as the actual severity score?
From what I recall, yes.
At what point in the process of the investigation did you do so?
It's a required field. You can't exit the report without at least putting a actual severity level. Like I mentioned, it can change based on the investigation.
Did you ever change
No,
these
I did
scores? So you put these 4s in, did you have to put those in the day that this first came to your attention?
Yes.
And is there a reason you never changed them from a 4?
Again, even as the result of the root cause, we still were struggling with a cause and effect.
And all these documents that I've shown you today, are they a true and accurate copy of the documents created at that time?
I believe so.
Right. And these were all kept in the normal course of business?
Yes.
No further questions?
Mr. Byers?
Like, I don't know,
Sit
there's
down
too many
at the
options.
podiums.
Like a buffet of podiums here. Okay.
Dave, would you go get that? It's not in the way.
That's okay.
Just pull it just that way, just a little bit. Puts out of everybody's view. That and the podium.
Sorry about that, Dave. May it please the court. Good afternoon, ma'am.
Hello.
Ms. Barga, so you are considered the patient safety risk officer at Mount Carmel?
That's correct.
And your job is somewhat legal, somewhat medical, right?
I don't know that I would use legal as the term, but patient safety is the main focus.
But you have to also deal with a lot of compliance issues.
We have someone who works on compliance.
Okay. So basically, we've heard a lot about how the voice reports were escalated, so I don't want to go over that too much. But I've heard you mention a couple of times that there's a scale all the way up to 9 on the numbers, right? And this one was put at a level 4, correct?
Correct.
And it is fluid, which means you can change it at any time.
Correct.
And it was basically your job to investigate what happened here, right?
Correct.
Okay. And one of the first things that, as soon as the voice reports were entered, and I want to make sure I start with the first one. This is just one page. Once a voice report is entered, there's a series of people who it goes to, correct?
Correct.
And one of those people, and I want to address starting off with Mr. Timmons, that was the first voice report, correct?
Yes.
And I am showing you page 5. I'm addressing specifically States Exhibit 22A. And as you can see, that is entered by you, right?
Yes.
And it addresses James Timmons, correct?
Yes.
Now, you see it's page 1 of 6 on the top right here?
Yes.
Okay, and I want to take you to page 5, and I am referring to Erlene Romine's comments, which is, it shows her the page before, sorry, page 4 of 6, follow-up actions, and you see right here Erlene Romine.
Yes.
Okay, you're familiar with this, right?
Yes.
So I'm just kind of doing it for the jury so we can follow along, and the record. Now, Ms. Romine entered in here that she needed more information, that these medications would be appropriate for a palliative patient, correct?
It appears that's what she entered, yes.
Okay, and part of your job was to go around and speak to everyone, right?
Not for every single case, but the ones that we get involved in the investigation, yes.
Okay, so in the process of that, you spoke with all of the nurses?
That was after the third event, yes.
Okay, but I'm going to try and I'm not specifically just talking about the first voice report, I'm talking about all of them now.
Okay.
So as you're investigating this, you start to speak to the nurses, right?
Yes.
And they're there day in and day out with these patients, right?
Yes.
And fair to say, Mount Carmel deals with a lot of special types of patients, like many drug overdoses, correct?
I would assume if that brings them into the hospital, yes.
Okay. And when you have a hospital in the urban setting, it creates different problems, or there are unique challenges than perhaps hospitals in more affluent areas, right?
Possibly.
Okay. You're aware that perhaps, we don't, certain patient populations don't have the same diet, there's more drug problems, that sort of thing, correct?
Okay.
Okay. Now, in light of that, the nurses at the bedside are perhaps the ones who have the most interactions with the patients, right?
They might, yes.
Well, I don't want to talk about mine. I want to talk about what you learned in the ICU. In your investigation, you learned, obviously, if there's one doctor for 30 beds, the nurse has the most contact with the patient, right?
Yes.
Okay. And they are in the best position to make the determinations or to, let me strike that. They're the ones who are perhaps observing more, right?
Of the patient?
Yes.
Yes.
Okay. And in light of that, that was important for you to go speak to them, right?
Yes.
And one of the things you learned were that many patients in palliative care unit, even though they, when receiving high doses of opioids, they still struggled, right?
In a palliative care unit, possibly.
And in palliative withdrawal specifically, in the ICU, during a palliative withdrawal, you learned in your investigation that even though they received high doses, they were still struggling.
Objection. What is the foundation?
Okay, well,
I think I laid it.
now, you got a little hearsay problem because you're asking for a hearsay answer. You're asking for understanding that's different.
It's your understanding that these patients were still struggling, correct?
What patient specifically?
Patients, after speaking to all the nurses involved in these matters, it's your understanding that these patients were still struggling.
Sometimes, possibly, yes.
Okay. Even after receiving high doses of opioids, right?
I don't recall if they said that specifically.
Did the nurses during your investigation inform you as to?
Objection. Hearsay.
Finish the question.
Go ahead and finish it.
Were you made aware of certain symptoms that they have to deal with?
You use that together, or was that a new question?
That's a new question.
That's a new
Trying to make
question?
it
Okay.
Can you please repeat the question?
Sure. Were you made aware of certain symptoms that they have to deal with as nurses during a palliative withdrawal?
I don't recall specifically, but it's possible.
Okay. If I showed you some of your notes when interviewing the nurses, would that help refresh your recollection?
Yes.
Okay. I'm going to have it marked for Sorry, give me a moment. Sorry, I can't even find my car without this guy. May I approach the witness?
You may.
I will list the people he spoke with, and then after that, arguments. That help you out a bit?
Yes,
Does that refresh your memory?
it does.
Okay. Now, these nurses had to deal with, well, what are the problems? Let me strike it. I want to make sure I don't elicit something that somebody told you. But it was brought to your attention as a problem in the ICU during palliative withdrawals, is that patients can suffer a lot of pain, right?
What was brought to my attention was the concerns about the dosages of medications.
Okay, my question to you is, there were a lot of things brought to your attention about the pain that these individuals suffered during palliative withdrawal, correct?
During the interviews with the nurses? Yes.
Okay. And one of the things that you realized or discovered during your root cause analysis is that the pharmacy could benefit from education about.
Hold on, stop. Who's phone? I hear bump, bump, bump. Huh? Maybe I need a vacation. You heard it too? Maybe we're going to require a hearing test this weekend for all participants. Okay. If it's somebody's phone, turn it off.
One of the things you discovered is that the pharmacy could benefit from learning the clinical picture of the patients, correct?
You may. It's been a while. Okay, come on. Yes, sir. Yes, let's take 5 minutes. Even though I gave you an opportunity to run earlier. Okay, remember the admonition, back in 5. You stand up while they come in and out. Just relax. I'm the only one who can technically sit, so, and I shouldn't, but I'm gonna have to move my chair over here. Did you hear the phone?
I could hear it, sir.
So y'all make me look like I was crazy, okay? Wow. I'm gonna have the deputies search everybody. Mine was right in front of me, it wasn't mine. I wasn't worried about you. It sounded like it was coming from over this way. Back behind the gate. You want to taser everybody? Okay, let's go on the record. good now? We're gonna continue on. Tobias?
Thank you, sir. Now, Ms. Varga, during the course of your investigation, there was an email that the prosecutor showed you that brought up the issue with the pharmacy. Do you recall that email?
Yes.
Okay. And that was brought to your attention because there was a concern that there was something wrong at the pharmacy, correct?
I'd have to see the email that you're specifically referring to.
I'm showing you States Exhibit 20F. Do you see that?
Yes.
And specifically, this is something that you brought to the attention of Larry Swanner, correct?
Correct.
And what is Mr. Swanner's position at Mount Carmel?
He was the Vice President of Medical Affairs.
Okay, so he's a big guy up there, right?
Correct.
And down here on the bottom, you say you wanted to copy him as well, since the pharmacy is concerned that the nursing staff is overriding the Pyxis to obtain and administer these medications.
That was addressed to Dina, yes.
Okay. You also became aware that there was an issue that the pharmacy was concerned about diversion, correct?
I think that came up in the course of the investigation, yes.
Okay. Now, it's a serious thing that opioids are being given to patients without pharmacy review, correct?
Yes.
Well, you would consider it.
Okay.
I can rephrase and move it along. You would consider it a serious issue as the patient safety officer if opioids were given to patients without pharmacy review, right?
It depends on each clinical situation as far as why the patient's receiving the medication.
I'm specifically referring to opioids being given to patients without ever having a pharmacist look at it. I'm not talking about emergency situations when they look at it later. I'm talking about pharmacy never looking at specific doses that are given to patients. That's a big concern as a safety officer, correct?
That would be concerning, yes.
In fact, it's against the law, right?
Possibly, yes.
Okay. And there could be an issue with the Center of Medicaid and Medicare Services, correct?
Could be, yes.
Okay. And in fact, as a result of all of this, that's exactly what occurred, correct?
I believe so.
Okay. They were placed in immediate jeopardy of losing all Medicaid and Medicare funding because opioids were being distributed to patients without pharmacy review, correct?
I don't remember the specifics, but
Okay. But that sounds about right to you.
possibly, yes.
Okay. And in light of that, ma'am, well, actually, let me backtrack and ask you this. Does a level 4 ever go up to Trinity automatically?
I'm not sure I understand the question.
Going back to the voice reports, does a level 4 ever get reviewed by anyone over at Trinity?
I can't speak for whether or not they would have access to review it.
What level of 0 to 9 requires immediate or mandatory review by Trinity?
I don't know that I can answer that.
Okay, so you have no idea?
I don't know.
Okay.
We would certainly escalate harm
Okay, hold on,
events.
relax. I know you want to help here, but he's got to ask you a question.
It's okay. You know, if you don't know, it's okay. We'd rather just have an I don't know than a guess, so it's okay. Now, in light of that, ma'am, I'm going to wrap up real soon. You ended up completing your root cause analysis in this case, right? And you just...
Well, he asked to write, that you didn't answer. Is that correct?
Can you repeat the question, please?
You completed your root cause analysis, right?
The paperwork, yes.
Okay. Now, in your root cause analysis, basically you were the person investigating these voice reports for the hospital, right?
It was a team of people, not just me.
But you led it, right?
Correct.
Okay. And when the police came to Mount Carmel to find out what was going on, you were one of the people who actually spoke to the nurses before the police, right?
I believe it might have been before, yes.
Okay. They never came to you and asked you what you found out, right?
They being the police? Correct, they did not.
They never came and asked you if you had recorded these interviews, did they?
No.
And they never asked you what you may have told them, correct?
No.
They also never asked you if you had notes of your interviews, correct?
Correct.
And no one ever came asking for your notes.
The police did not.
Okay. And there were plenty of notes that you had, right?
Yes.
You mentioned during direct examination, and I want to get your exact quote, that the 4 was never changed because you struggled with the cause and effect and ultimately determining that, right?
Correct.
Okay. And one of the, I have a copy of your root cause analysis, which we marked Defense Exhibit LK before. And I heard you mention during direct examination that you spoke with subject matter experts. Is that correct?
Correct.
And one of the things you did too is, I guess you attached an article titled Narcotic and Benzodiazepine Use After Withdrawal of Life Support.
It sounds familiar.
Okay. If I show it to you, would that refresh your recollection?
Sure.
This is the article you attached. May I approach?
Right.
Yes.
And for the record, again, this is LK.
Slow down. Any objection?
Yeah, I have an objection.
Okay. You
We
may.
spoke
Come
during
on
the
up.
break, and she said she didn't have a problem.
No, I have an objection to specifically.
Come on, no walk, come on up. Busy. Come on. Help me out.
Can you, I don't want to zoom, I'm going to zoom in a little bit. Do you see the conclusion at the very bottom of this page of the
Yes.
article?
Yes.
Okay, and of course you found it important to attach this article to your root cause analysis, otherwise you wouldn't have attached it, right?
Correct.
Okay. And the conclusion of this article says that we found no evidence that the use of narcotics or benzodiazepines to treat discomfort after withdrawal of life support hastens death in critically ill patients at our center. Clinicians should strive to control patient symptoms in a setting that and should document the rationale for escalating those drug doses. See that?
Yes.
highlight this portion during your root cause analysis when you turned it in?
I don't recall.
Okay. I have no further questions. Thank you.
Redirect? Okay.
You want me to read this stuff? All right.
Ms. Berger, you indicated you're an RN, correct?
Correct.
And on cross, it was pointed out, these medications would be appropriate for a palliative patient, correct?
Yes.
And then this detail, many pharmacists are concerned with the high dose. In your experience as a nurse, is there...
Objection.
Okay. We got the problem from earlier.
In your current role, do the words medication and dose have different meanings to you?
Yes.
And can you explain that, please?
Medication is obviously something that would be given to a patient to treat some type of condition. The dose of that medication can vary depending on what the patient is being medicated for.
So, hold on.
Sorry.
So when you say that, do you mean like the strength of the medication then?
Correct.
Okay.
So did Ms. Romine indicate that the dose was appropriate?
Objection.
It's right there.
Well, the document's right there.
Right, the document speaks for itself. She's asking for more information other than what's in the document.
I'll withdraw the question.
Okay.
On cross, did you indicate that the police did not ask for your notes?
They did not ask me for my notes, correct?
Did anyone ask you for your notes?
Yes.
And who was that?
I believe my boss, from what I recall.
And do you have any understanding as to why?
I think it was just...
Wow.
And speculation.
Do you have an understanding of why?
I do.
Go ahead.
Can you tell us that, your understanding, please?
Sure. As far as all of the patients that were identified during the course of that investigation, it obviously required more people than just myself to have eyes on the information.
And the article that you were shown on cross, how did you get this article?
I believe one of the physician subject matter experts from the root cause analysis brought it to the team, from what I recall.
And when you attached it, were you endorsing that article in any way?
It was just part of the investigation.
Right. No further questions.
Okay, ma'am, you may step down. Anybody else? We still got half an hour. Or am I pressing my luck? Okay. I'm gonna force you guys to go home early, I'm sorry. Okay, we're gonna get started at 9 o'clock in the morning. Remember, time is gonna be tight on Monday. We'll probably only do an hour lunch because I have a doctor who can only be here for so long. Okay? I warned you. And is there more than one tea drinker? I was gonna bring an electric teapot so nobody burnt the place down. So I should bring two? Well, this is out of my personal collection, so let's treat them with a little loving. Okay? Now, let me caution you guys, it is particularly, you're through your first week. It's particularly important that you don't discuss your case. Okay? We don't want to have to go through things. Okay? So, bottom line here is, don't discuss the case, don't do your own investigation, because you're going to want to look up terms and stuff. Don't do it. Okay? Don't pay any attention to the media. Okay? And finally, have a great weekend. All rise. Be safe. Hopefully we don't get an ice storm tonight. Yeah.
It's Jill's birthday this weekend.
Okay, you didn't listen to me the other day.